to the Masterclass on Lower GI Live webinar organized by APELS Asia Pacific Endolab Surgery Group. As a medical academic group, APEL pushes the frontiers in the field of endoscopy, laparoscopic surgery in the past 7 years, providing a platform for the professionals of the field from all over the world to share the up-to-date information and innovative ideas through physical training workshop and virtual events. Before we begin this event, I would like to express my heartfelt gratitude to the course director of this 2-day localized hybrid module in Philippines, Dr. Alan Buenafe and Dr. Ray Sarmiento, who sincerely committed to make this event a success. The event would have been impossible without the support of them and their team. The training program capitalizes our strength and realizes our commitment to the endolab professional to cultivate a learning culture and enhance professional competence in endolab surgery to meet the ever-changing challenges in today's clinical areas. I would also like to take the opportunity to welcome the doctors who are attending the 2-day training in the Philippine Center for Advanced Surgery in Philippines. I hope you enjoy not only the sharing of the experienced surgeon through lectures and discussion and live webinar today, but also the endoscopic laparoscopic hands-on training tomorrow. It is certainly a valuable opportunity to experience the latest 3D endolaparoscopic equipment and ultrasonic energy device sent directly from Olympus Regional Office solely for this workshop. For the webinar today, it will be put in 2 key parts. In the first half of the event, we capture the essence of APEL's legendary workshop with the presence of some very notable speakers from the Asia Pacific regions. Professor Joel Leroy, Professor Craig Lynch, Professor William Chen, Dr. Alan Buenafe, and Dr. Jiunn-Herng Lai to share the basic and best practices on lower GI management in combined endoscopy and laparoscopic approach. Dr. Ray Sarmiento is our moderator today to lead us through the sessions. Second half of the after an hour break time, we will kickstart the troubleshooting with expert session. Each of the 5 enthusiastic young Philippine surgeons will bring to stage a difficult lower GI laparoscopic colon surgery case they encounter. Dr. James Tekchesi, Dr. Wilma Alonso, Dr. Ralph Yap, Dr. Ismail Mahani, and Dr. Jesus Dabalos will share their learning experience, difficulties with the faculty, and discuss the approach. As the chairman of APELS, I look forward to the rapid growth of society, and we will continue our commitment to educate, train, and innovate in every aspect of endolab surgery. Once again, I welcome you all and sincerely hope you will enjoy the program online or in person in Philippines. I wish this training program enlightens and provide you with practice approach to deal with the everyday challenges in your work. Thank you.
Thank you, Professor Lee. Good morning. Good morning, everyone.
Good morning.
So, yeah. As mentioned, this is an APELS localized hybrid module in a masterclass in lower GI. And I have here Dr. Buenafe as a course coordinator. And today we'll have the didactics in the morning, video presentation in the afternoon, and then tomorrow we'll have this endolaparoscopic hands-on module for our participants. And it's nice to know that most of our participants are colorectal fellows and advanced MIS fellows in training. So that will be the gist of our APELS workshop for 2 days. Professor Lee, without further ado, I'd like to give you the floor back to you for the lecture on endo-laparoscopic approach for lower GI.
Thank you, Ray.
Thank you, sir.
Okay, well, I'll kick off the morning program. Basically, an introduction to what our thoughts about using a combined approach for lower GI tract. Well, minimal access surgery, it really talking about reducing the size of incision. And in fact, this has been a dream of surgeons for thousands of years. There's a famous saying from Ronald Mavick, who postulate surgical technique will more or less be a combined technique in the future. This happened about 30 years ago. So, minimum access surgery is not new surgery or new procedure, but a new approach to what we traditionally do with the open surgery. To me, minimal access surgery means using endoscopic work, using the endoscope, and also, of course, the laparoscope, which everybody initially thought minimal access surgery is all about. Well, we have postulated that the future surgical technique is going to be a combined approach because individually there are limitations in laparoscopic surgery itself and endoscopic approach by itself. So if we combine the two together, their role will be complementary. As you can see here, there are some examples I put up on the screen. You can do combined laparoscopic cholecystectomy with on-table ERCP. And you can do mucosectomy or ESD under guidance of the laparoscope for difficult areas. Or rigid endoscopic approach to retrieving tumors or removing tumors. And of course, intraoperative endoscopy for combined approach. So here's the concept of endolaparoscopic surgery. We combine the two surgery together in the same sitting. And this is our idea of endolaparoscopic approach to our disease process. I was the first one to develop endolaparoscopic OR. This happened physically over 17 years ago. The thought came to me when I was talking to the then head of Olympus in Hong Kong, Mr. Max Lun, in our Bali meeting, and suggest why doesn't the company think about combining the two systems which they already have in one OT setting. So we built this OR, and we actually did some study to show its effectiveness. And we published this paper back in 2006 already, showing this OT design had reduction in OR setup time. There are 46% reduction in turnover time and 60% reduction in time required to set up additional scope. And this is compared to what we had to do without this combined equipment. So the integrated OR of endolaparoscopic approach is making easier for the surgeon and simpler for the operating staff. As you see in the equipment room, nothing lying on the table, lying on the floor with wires. Everything is on pendant. It, of course, it's improved the safety and it's better for the patient. The first we got to use this was on table colonoscopy. It was, most people were quite worried about using on table colonoscopy because they had to put out the extra equipment. But in effect, in the days of MIS surgery, we were given a lot of colonic tumors, which are early lesion, and they cannot be localized by visual field under the laparoscope. So of course, you can do intraoperative localization of these lesions. Of course, you can also remove synchronous polyp before your colonic resection for whatever indication. You can use a laparoscopic assisted approach by putting the colon in the best position for resection. And of course, at the end of anastomosis, we can perform a leak test, particularly for the left-sided anastomosis. And this is just a picture to show how an intraoperative post-anastomosis bleeding, which are identified from the suture line, and one could immediately perform hemostasis with a surgical clip. Of course, this saves the patient postoperative readmission of bleeding, and this shown in the original article in Surgery Laparoscopy as early as 2012. Now, we already have 20 to 30 years of history since the start of the first laparoscopic cholecystectomy. And due along the time, various new tools and new approach will develop to extend the scope and application of MIS. At one stage, the thought of nodes, natural orifices in endoluminal surgery had been advocated, although it never became a very successful procedure like transgastric appendicectomy. At one stage, we got the publicity, but never practically worked. However, it led to a lot of thoughts about using the endoscope in the intraperitoneal cavity. And one of the endoscopic approach is using a rigid endoscope, as you can see here, to do rectal lesion. So it's a transrectal endoscopic procedure. We have thought about combining the two approach as early as the 2000 and reducing any trauma to the abdominal wall besides trocar wound. And that is doing a colectomy with a endoscopic removal or assisted instrumentation to perform this procedure. This is to show here a lesion being identified in a sigmoid, an early lesion of tumor. A standard approach of mobilization of the sigmoid and rectum was performed. And then The rectum is mobilized to the upper aspect. Irrigation is performed, followed by insertion of the rigid endoscope, the TEO device. Now, with this advice, pneumoperitoneum is maintained because it's also insufflated with CO2 to perform the procedure. So the resected specimen is under visual control, removed through the open rectal stump with the TEO device. And this followed by transection with the GIA and a double shaping technique performed. And this is, so with this thought, we actually managed to perform a trial. Well, this is the initial report of our work back in 2009 with the availability of the EndoLab OR. Then we went on to do a trial to show the effectiveness of this against the conventional laparoscopic colectomy, where you require to have an open wound to extract the specimen. I just like to point out to you, at the time of this trial, we have shown pain score is significant and the wound infection is significant in the findings. Intermediate result and the 3-year survival rate is shown here, which is of no significant difference. So it's safe to perform hybrid nose colectomy on selected patient, and it doesn't seem to adversely affect the oncological outcome and survival rate. Now, moving on to intestinal obstruction, which had been particularly left-sided intestinal obstruction, can account for up to 40% of colorectal cancer, and something like up to 30% present as intestinal obstruction. In the past, most of these patients would receive either Hartmann procedure or one stage on table lavage and anastomosis. But most would practice a Hartmann procedure. There's an overall mortality rate of 13% from morbidity of the stoma, patients have poor quality of life, and reversal needs another risk of GA or laparotomy. And at the end of the day, 50% of Hartmann's was not reversed. This is the color trial for laparoscopic colorectal resection, and it had really shown the benefit as early as the 2000, where various trials demonstrated the use of laparoscopic surgery for colorectal cancer. The problem of obstruction is high morbidity, high mortality. Usually patients with these have worse oncological outcome, and in particular, laparoscopic is not possible at acute situation. But maybe this can be reversed by first using colonic stenting via the endoscope. So we're combining the endoluminal stenting to laparoscopic colectomy. This is see the difference between a patient who had open Hartmann procedure and a stoma, and somebody who received this endo-laparoscopic approach. And that's the result of the abdominal wall. So we need to assess whether the patient is suitable for doing this procedure. And we reported our initial result in the treatment of obstructing left stomach cancer in 2009. And basically, with this result, we show that this is one-stage procedure possible by initial endoscopic stenting followed by laparoscopic approach, and definitely reduce the incidence of stoma creation and really make the patient benefit for the full enjoyment of minimally invasive surgery. Of course, there were criticism whether we're doing adequate surgery, and this is what we showed the EndoLab group for the average lymph node harvest, average overall survival rate, and 5-year disease survival rate is better. So, and also it does not adversely affect the oncological outcome of the patient's survival. So, ladies and gentlemen, I think in this phase of minimum access surgery, as you see throughout the years, we have been continually innovating and develop and improve and discover new frontiers for the betterment of our patients' care. I thank you for your attention. We need to unmute Ray. We can't hear Ray. Sorry.
Professor Lee, thank you very much for that lecture. Surely it's an eye-opener for most of us here in attendance that slowly becoming an approach that's we all need to do as a general surgeon or a colorectal surgeon. And it's inspiring that you started this program of APELS with the EndoLap approach. And I hope the guys here who are joining the workshop will be able to pick it up. As you know, in the country, the endoscopic part or the flexible endoscopy part of training is not it's still immature, and we'd like to mature that. We'd like to go more or advance more in terms of endoscopy. And probably can you give a or can you comment? You've been around the world and you've seen a lot of training programs with regards to general surgeon picking up the endoscope. And can you comment on that? Because our training program does not lean on having the surgeon use the endoscope. And of course, I think you will agree that training surgeons to use the flexible endoscope will be very, very useful in our service delivery in the country.
Yes, Ray. I think 20 years ago, I don't think any of the European or American surgeons would think about using endoscope because it is not in their confine or training. It very much rests in the hand of the physicians and also the training program by the physician. But times have changed. And in effect, if you look at both SAGES and EAES, they now have curriculum for endoscopic training for surgeons. And training courses around the world are starting to do this. But of course, you know, APELS have started training this since 7 years ago. And we've been promoting this in various training courses that we do. So this is picking up. But to besides able to do the procedure, you have to be able to do the procedure in an environment that's familiar to your setting. As a lot of times in endoscopy center, they're dominated purely by the physician who runs it. But if you have an endolab OR, you can do the endoscopy in your OR as a combined procedure, or ability to use it because it's in your own confinement. So I think the attitude is going to change. I see a lot more young surgeons able to do endoscopic procedure through the basic training, building up to the advanced training.
Thank you, Professor Lee. So I think the solution is to have your own endolap OR. So,
as I always say.
Yes. Okay, sir. So without now, I think we are ready for the next lecture. Thank you very much, Professor Lee.
Thank you.
So before giving the floor to our next lecturer, we'd like to properly introduce him. And the one who will introduce our next lecturer is Dr. Kevin Apeles, a graduate of our UMIS program, Advanced MIS program. Kevin?
Good morning, Professor Lee, Dr. Buenafe and Dr. Sarmiento, and to our participants. I am Dr. Kevin Apeles, and it is my honor to introduce our first expert speaker for today, Dr. Lai. He is the director and consultant surgeon at Lai Endoscopy and Colorectal Surgery in Singapore. He is head of the overseas operations of HC Surgical Specialist. He is also a specialist general and a colorectal surgeon in Mount Elizabeth Hospital in Singapore. He's a member and a general surgery representative of the Medical Advisory Board of Mount Elizabeth Hospital, a member of Singapore Cancer Society, Colorectal Cancer Awareness Month Steering Committee. He is also a board member and faculty of APELS and a lifetime member of ELSA. Let us all welcome Dr. Jiunn-Herng Lai for his lecture on advances in endoscopy for lower GI lesions. Dr. Lai, good morning.
Professor Lai, Dr. Jiunn, you're on mute.
Okay, thank you,
Okay,
Kelvin.
got you.
Thank you, Professor Lee and APELS for the invitation, and Professor Alan Buenafe, as well as Ray Sarmiento. Thank you very much to this localized masterclass. Good morning to all the Philippine participants at PICAS. I wish I'm Dr. Lai from Singapore. I wish I was there with you in Philippines, maybe sometime soon. But today we are going on to the webinar on advances in endoscopy in lower GI lesion, and I hope to share with you some of the new advances as well as approaches that we surgeons can do in endoscopy. Essentially, it is endoscopic management of colorectal polyps is one of the most common lesions that we manage in endoscopy. So I'm going to go bring you through what's best and what's new. This is my logo, the happy colon. A happy colon is somebody who comes for screening, surveillance, and gets their polyps and cancers removed happily by colorectal surgeons like us. All right, what is the scope of my talk? What's new in endoscopy for lower GI? I'll give you an introduction to EMR, ESD by surgeons, EMR equipment, some videos, and some preparation and recovery for those of you who want to start your own cases. So what's new? I think endoscopic surgery by surgeons is, to me, fairly new. Endoscopy by surgeons is practiced by a lot of us in Asia. I guess it's also new for places like Philippines and the US and Europe in the last 10 to 15 years. All right, endoscopy with robot platform is something new that I want to share as well. And of course, the latest artificial intelligence with endoscopy. So what's new is the endosurgeon. All right, endoscopy is sometimes quite a lonely thing. You can't really have much assistance in when you're actually doing the scope. You're handling the scope, you're having instruments that you need to manipulate by you or your nurses through a small little port or even 2 ports. And therein lies the challenges and yet the training value of such an endoscopic platform when it translates to a laparoscopic or robotic platform that we're used to doing for colorectal procedures now. And really, the practice of advanced endoscopy includes utilizing or learning endoscopic and laparoscopic skills. And a common procedure that we will do more than most will probably be something called endoscopic mucosal resection for most large polyps. Doing a transanal endoscopic operation combines these skills together as well. And the most important thing is if you can wield the laparoscope and endoscope with ease, that will bring most colorectal surgeons to current and future practice. This is some of the polyps that we talk about that are large for removal. I think more than 15 years ago, I wrote a paper with my then department, SGH, about laparoscopic resection of large polyps. After that paper, I realized that we actually have a lot of benign polyps that could have been done through the endoscopic technique if they were having the skills at that point in time. And that started off my learning and practice of endoscopic mucosal resection techniques. So like some of these large polyps, using different equipment to remove them endoscopically. A lot of more toys to play if you do endoscopic surgery. And then this is a recent large lateral spreading polyp that we removed, and some more toys to use, which is different clips. I think some of the basics to share with the audience, all right, that you've got to be familiar yourself with if you start doing endoscopy for lower GI lesions is lifting the polyp. All right, so a variety of techniques, just like doing laparoscopic surgery, that you need to learn. And one of them is lifting the polyp, provide that additional 3 to 4 mm cushion of space. Here, I'm injecting with indigo carmine at the first outset. All right. And then thereafter, I will use something called the Ori's gel. A basic technique of EMR can be similar to polypectomy, but using, I guess, large or larger and stiffer snares, all right, understanding your snares as well. So there, in this procedure, we're using the suction and traction technique. So you can see a lot of bubbling. You can't really see what's happening until the end. I want to show the next video. I think this video, sorry about that. I was going to show you something about this technique where utilizing the snare and suction can go a long way in removing large polyps. So this you have a 33 mm snare, and there I am turning the snare around, flipping across to this polyp, flat polyp. I created a lip at one end with the hot biopsy forceps, all right, so that there's some traction. And thereafter, you can see that you can then tract it into the snare fairly easily to do this EMR. Clips are another things that we want to familiar ourselves with when you do endoscopy for lower GI lesions. Here's one of the common clips that I use, what we call the Boston resolution clip. Right, it's important to clip the lesions not mainly for cosmetic purposes, all right, but they do bleed after or at the end of procedures or when the patient's in recovery, simply because there's nice blood vessels at the edge of the mucosa. And then most of the clips are done for this purpose in hand. The other technique that you need to be familiar with is, of course, putting multiple clips, all right, and in locations that may be challenging, like the hepatic and splenic flexures. Utilizing the air as well as the endocuff as a stabilizing procedure. Another new development is using the robot system. As you can see, this is the Flex robotic system on a scope. You can see on the picture here, there are 2 arms, all right, which makes life more easy as an endoscopist, because most of the time you only have one instrument sticking out. Now you can have 2. Now this is on already moving and approved, getting approval in Singapore. So if you can imagine, for the surgeons in the audience, from laparoscopy to rigid robotics to a flex robotic system through the anus. And this is a new tool that we can use for EMR, ESD, transanal surgery, and perhaps have more control and more space. This utilizes a system here where the flex scope is moved with your right hand, all right, through a system like this, as you can see, pushing it in and out. And once you're in the space that is that you want and stabilized, you can then use both arms on another console to control the right and left arm of the instruments. All right, it actually has a passive 3D view, or everybody can see a passive 3D view on the TV screen. All right, and you can see the camera systems with 2 cameras and HD cameras providing a 3D image. All right, this is one of the starting videos that we did. All right, and this is a small polyp, but we're just practicing. But as we are moving in, you can see that there's a bit of jerky movement, not the same as the scope. We move to where we want to. In this case, I think it's a upper rectal or distal sigmoid polyp. Right, the reach of the flex robot is mainly to about 30 to 40 cm from the anus, so more than your usual endoscopic TAMIS or what we call TEO device. Right, but you can see the flex instruments provide the flexibility just like laparoscopic surgery. All right, and here we are marking it out. All right, so really this is a real evolution. It makes endoscopic procedures much easier with 2 arms, like what surgeons are used to when we operate laparoscopically. All right, so this is no different from surgery, all right, except you're operating in a smaller space. It's like single port or like your TAMIS that we do. All right, and after removing it, the polyp in a whole piece, this can be used for ESD, EMR, all right. After removing it, the beauty of it is there you have it with 2 arms, nice stitching, all right. You don't need to put metal clips that I'm used to putting for just a usual endoscopy, all right. And that's also something that surgeons are very, very used to. All right, so that's for the flex robot. Now the Endo Master is something on trial already in use in Chinese University of Hong Kong, but they were developed together with the National University and the Nanyang Technological University of Singapore. All right, and this is a real full scope system that goes all the way, just like a scope to the cecum. All right, through the scope, there are 2 robot arms. And frankly speaking, it's already on trial and use in parts of Hong Kong. I wish you will come back to Singapore soon, and I'll give you more information on that. The next is artificial intelligence in endoscopy. This is the Medtronic GI Genius system. And what happens is that you can see the green box is picking up and giving flashing green box view to the endoscopist, all right, to highlight and in fact has a faster response time for most endoscopists to seeing especially small polyps. And this is something that has been up and new and currently moving. I have tried this system myself in Singapore. It's very valuable, not only to learning or junior endoscopists. All right, I feel there is a role in routine endoscopy, even for senior endoscopists, because of its speed of detection, its ease of use, as well as the increased polyp detection rate. So there you see it. As you pull out the scope, it's showing you where the things, where the polyps are, and you can remove them. All right. So routine colonoscopy has up to about 20 to 30% calculated adenoma miss rate. All right. And hence, with this enhanced detection system, that frankly speaking has no risk to the patient. All right. It has met with skepticism at first by endoscopists, and but for those who use it, we realize that it is a valuable tool. Now, I think in my practice, especially for a few things, small polyps, because we surgeons tend to do scopes relatively fast. 2, in certain situations of slightly poorer bowel prep, or in things like melanosis coli, where there's a lot of confusion in the mucosa, it helps you really to focus on the small polyps that you may have inadvertently missed as you go about routine, and then you can just focus on the polyp and review it slowly. Right, so this is a valuable tool, and it's very easily integrated into any of your endoscopy systems. Let's look at some, so it's a seamless integration, all right, into the system. You just plug in the video processor into this intelligent endoscopy module. All right, as you can see, a whole range of polyps that will be useful, especially the small ones. Small sessile serrated polyps are not easy to see. All right, the very tiny 2-3 mm adenomas behind the fold, especially. Just as you pull out the fold, you suddenly see a green spot, and you go in and have a look at it, and there you have the polyp. So I found this was initially met with skepticism by me, but I found this is good in routine practice, except it's a bit expensive, the software, the apparatus from Medtronic. All right, so what it did in some of the randomized controlled trials, it showed the reaction time is 82% faster than expert endoscopists when they each asked to press a button to detect the appearance of a polyp. That's important when you do scopes fast, because you would have missed that polyp if you didn't see it as fast, because we tend to go past folds quite fast for most of us in a busy practice. So that's important. All right, sensitivity is high and very low false negative. So if you look at the numbers in this study by Replici in gastroenterology, the adenoma detection rate has increased 15%. Adenoma per endoscopy increased 45%. And really, there's no impact in withdrawal time. A lot of expert endoscopists think they will slow them down because we keep looking at green images, but that's not the case in my practice. Now, the locations that matter in this trial in gastroenterology, evidence-based is that in all histology types, we do have an increase in detection rate. Number two, distal colon actually has a higher detection rate compared to proximal colon polyps, possibly because we tend to pull out the distal colon relatively fast. In the proximal colon, we take our time to have a look. All right, and really, if you look at this, evidence-based is that the smaller polyps, less than 10 mm, are the ones that has an increased detection rate with this device. All right, so some of the RCTs really do show nearly up to 50% reduced polyp miss rate on initial colonoscopy. And I think some tips and tricks that you still need good brow prep. Give us some time to get used to the green flashes. But more importantly, you're having a partner with the AI. You're not competing. Just like the robot that we do in surgery is not going to replace us yet. We still got to do the endoscopy and just pick it up with better pickup rate with the artificial intelligence. All right, just move on to the rest of the lecture. This is me 5 years ago when I opened my private clinic. Just to bring this to Singapore, that our colorectal cancer rate is still among the top 20 in the world. And that's why we're still in, they still need colorectal surgeons like us. And I would say this polyp was one 47 cm polyp that I removed from the upper rectum years ago. Would it have been gone for surgery if we can't remove it endoscopically? Definitely yes. So you've got that skill. You need to develop that skill so that you would have majority of polyps amenable to safe endoscopic polypectomy. All right. And then I think these difficult and complex polyps, the size, more than 1/3 circumference is no longer a barrier. Even difficult anatomy can be overcome by techniques in endoscopic surgery, endoscopy. So these are some of the polyps that we use to subject them to laparoscopic surgery. But I think nowadays with good endoscopy, EMR, ESD, these can be removed as long as they are benign. So I think endoscopic mucosal resection treat most mucosal lesions. Submucosal dissection, I'll talk about it. I guess you can treat those with focal adenocarcinoma or those early cancer with SM1. We'll talk more. But the most importantly is to know what are endoscopic characteristics of malignancy and submucosal invasion. So there I'm coming down to a little bit more didactic for the surgeons in the audience who perhaps do less endoscopy. Got to familiarize yourself with quite a few classifications. This Paris classification is on morphology, and that correlates with how deep or how possible this is in terms of a cancer or early cancer or just a benign mucosal polyp. Next is the kudos pit pattern, very commonly used as a classification. With using chromoendoscopy, most of the time you have one or two, kudos 1 or 2, which is very, very benign and hemohypoplastic. And in the past, people don't remove them at all. Right? You get the adenoma patterns, which is 3 and 4, which is amenable to EMR. And then once you reach kudos 5, you probably should consider surgical treatment. Another common classification I use is the Sarno's capillary pattern, and that's because a lot of scopes have the NBI in them now, or narrow band imaging. You can see the nice pit pattern. For a surgeon, I teach my trainees, if you look at the polyp and he has a nice pattern that looks like the brain, regular ones, you probably just remove it by the endoscopic technique. If you start to find them having a very bizarre 3A or 3B appearance, you got to consider a specialist review like us, or even consider surgery, because these will be more towards carcinoma. All right, these are some pictures of what we do for EMR and ESD. But what I'm going to do is essentially EMR, lifting the polyp. If you can snare it just with a couple of different type of snares, either with or without a cap or traction approach, that's what we do. All right, that's essentially is a big polypectomy with the use of different instruments. All right, and hence the criteria for me has increased from 2 to 3 cm in size. Most importantly is whether you can assess the base, that means see where the base is, the entire base, access it by the scope, or whether you can lift it up submucosally or not. Once you can do all that, and you can exclude malignancy or the endoscopic characteristics, every of these large polyps can be done by EMR. The surgeon's perspective is a bit different from the gastroenterologist. I think there are some gastroenterologists who are very finicky. They want to have a whole entire piece EMR. They are more finicky with a few things. But I think the surgeon's approach is quite what we call quick and dirty. I think a dedicated endoscopist and surgeon can handle complications from EMR, handle the surgery if need to be, and in fact, understand the specimen and histological implications better. We can understand the limits. We can also offer aggressive surgery if we cannot complete the EMR. And essentially, we can use endoscopy and laparoscopy approaches to give us the best view of the endoscopic resection. So hence, in my practical approach is, as long as you can remove the polyp, whether you do an en-bloc or what I call a smart piecemeal, that means you remove everything and send it for histology, it's not a problem for surgeons, because if there's cancer in the piece, you can offer surgery as an option. All right, and you know which pieces and where you remove them. I think some of the risks of EMR include primary and delayed bleeding, perforation, and recurrence. Hence, you really got to survey them. All right, so I'm going to go to a little bit more technical now on for the audience. All right, so this is some of the assessment of the polyps. So if you can see this polyp here, all right, I'm not just looking at the size. I'm going to use some instruments to test whether they are mobile. Like you can use a forceps to test whether they are mobile, soft, all right, or stuck. Just like this polyp initially presents really large, all right, and what I did while looking at it was, I suss it around, I look at the base, I touch it a little bit, I go behind. This polyp actually has another 3 cm in front and another 2 cm behind the fold. All right, but you can see that it's hanging loose on the mucosal, so probably it's just a mucosal polyp. Now this is a bit more challenging. This polyp, if you look at it, it's a lateral spreading tumor. It's actually very flat and a lot more ugly looking. So I guess for me, a good assessment is very important, all right, before you move on. I do not do, sometimes when you do a primary endoscopy, I don't do the EMR at the same sitting, especially for these types, because patient may not be prepared for the kind of complications that they have. And oftentimes we do either a quick biopsy or we take some good, nice photos and come out and explain to the patient that they will need a more extensive procedure, some of the increased risk of bleeding and perforation, and then move in another day to do it, especially if you don't have the skill and need to get somebody else who can do it for you. All right, the bowel tattoo as an indicator of where this polyp is very important, so that if it turns out to be malignant, or there's complications, we can go and handle it laparoscopically, because you really can't feel it. All right, and we don't do open surgery for it if we can, because it's a polyp. So really a submucosal injection technique in 4 quadrants. Usually I will use a spot ink, all right? And this is one of the ways to do it, all right? All right, a nice injection, all right? Submucosally, all right, to achieve, and then do it in 4 quadrants. Now, mind you, this is not without its risk. If you inject this intraperitoneally, you can get some small degree of sepsis or pain to the patient. So if you do that, sometimes it's good. give the patient a couple of days of antibiotics. All right, if you're on your start of your learning curve and you find that the injection, instead of being submucosal, has gone straight in. All right. So ultimately, what you want to see in laparoscopic surgery is this. You want to be able to see a segment like here, right in front of you, 3 quadrants or 4 quadrants of nice submucosal injection, so you know where to do your distal transection or where the polyp is. Now, submucosal injection is important to raise the polyp. The highlighted green ones is what I normally use. I test it out with a bit of indigo carmine and saline, so I know that it can lift. And then I put in this thing called the Orice gel from Boston, which is basically a food-grade starchy injection. All right. And I find that it stays in for at least for about 20 minutes for me to do the EMR. I think there are a lot of other injection agents to give, including dextrose water, hyaluronic acid, but some of them are very expensive. Some of them have an allergic reaction, and some of them, if you just inject saline, it disappears quite fast. All right, so this is what we do with lifting the polyp. I think we have seen this already earlier on, so I won't go through this video. I'll go through this one where this is the huge polyp that we want to lift as well. All right, so as you depress it in and lift it up, it really provides that cushion, but you've got to have some strategy. If you lift it up the wrong direction, the polyp actually moves backwards. So for this polyp, I wanted to move forward. I wanted to see the polyp that was hanging around behind the fold. So that was part of my strategy, and you just got to give a constant pressure, all right, and constant injection to lift it up and give you that cushion that you need. Snare, knowing the instruments to do your EMR is very important. The size of the snare, how to manage the mucosa, use of energy. This is a common snare that we use, a Captivator 33, that can handle most polyps up to 3 to 4 cm in size if they are soft polyps. All right, so this will be very workhorse of my usage. All right, the stiffness of the snare works especially for very small and flat polyps. And some of the mucosal capture techniques I tend to use is what we call a lift and cut technique that you've seen with a bit of mucosal suction. You might need a cap or like a what we call a ligator cap, all right, to plug in so you can see closer to the mucosa. All right, so these are some of the techniques that I think are useful. Next, let's look at some of the action of the snare. Okay, in this video here, I'm actually snaring the portion of the polyp that's behind that large polyp that we saw just now, all right, to provide me with a little bit of a lip and a space. Okay. And then once I do that, if you see the next video, I'm able to then snare the main polyp. You can see the utility of this 33 mm snare. It's really a round snare that can go all the way. All right, and so what I'm doing now is I'm providing suction, all right, in my CO2 endoscopy, so that using that to bring it in.
Dr. Jiunn, excuse me.
Yes.
I think your slides just stopped.
Is it stopped?
Can we go back to the one wherein you're showing snare?
Yep, I can do that. Give me a while. I apologize for that. Am I sharing now?
Yes, sir.
Okay, so I apologize for that. So this part of the video was on, I'm just repeating myself, on doing the mucosal techniques to show you, all right, in a big polyp that has, this is an additional segment behind that polyp. So I did that first. I did the behind the fold segment first to provide a bit of a lip and for my traction of the front polyp. All right, thereafter, you can see that I'm moving forward. On the left of the screen, you can see the defect left by the other part of the first part of the EMR. And now I'm doing the main EMR and using suction and traction techniques to wheel the whole polyp in. So essentially, you're using air and suction as your other arm, all right, because you can't push the colon towards you, all right, and using the snare as your left as well as your right arm by providing traction yourself and pushing the snare in to do the EMR. So there you can see the whole piece that has come up. This is the EMR that's done, and oftentimes you need to assess the base for bleeding as well as for the size. So in this situation, this was one of the lateral spreading tumors that we saw. We had to assess the base because there was a lot of, it was almost hemi-circumferential, as you can see. All right, one whole round circle. I'll show you a bit later on how we clip this. All right, and assessing the base is an important aspect of the strategy of applying the clips. Now, before you apply the clips, think of your retrieval technique. There's no point removing the whole polyp very well and then losing the polyp. So using a combination of net as well as grappling forceps are important. All right. Pitfalls are lost specimens in flexures or dirty bowel preparation. And also try to retrieve it before you put the clips, because if you use a net, you can get snagged into the clips on withdrawal if you're around that area. All right, so these are some of the things I use. A rescue net, grasping forceps, commonly used to grasp the polyps. And this is just a simple representation of how the rescue net works. All right, there are many different types of net, but this particular one from Boston has a very safe, because it's a edge lined by Vicryl rather than by a stiff metal equipment. All right, so this will allow you to pull it out of the anus without losing the specimen. Next is you're going to invest some time in looking and knowing about your clips so that we can close the mucosal lining. So this is the lateral spreading polyp that we removed earlier. All right, and we have some strategies of putting multiple clips, so one after another. Usually, you tend to think about dependence. So you put a clip and let it hang down so that it can show you the feature. It's sort of like a following stitch. You put a stitch, you pull, that's what you do for surgery. And then for here, you've got to use just gravity as well as different positions to help you in the clip. All right, this is the same patient with the hemicircumferential wound. All right, so we're applying clips multiply. I've still got another ways to go. All right, and then there, sometimes you do a bit of a clip in between your clips as well. All right, so, and there, I managed to close the whole specimen with about 6 clips. I think this polyp was about 6 cm in total size. All right, in various locations, mainly because of the lateral spreading. That's why it looks like that. All right, I'm just going to talk a little bit about endoscopic clips. There are variety depending on your country that we use. In Singapore, generally it's Olympus as well as Boston provides us. All right, and we use clips for all these conditions endoscopically. All right, usually for post-polypectomy as well as for GI bleeding and ulcer. And I think it's important that you know your clips, how smooth the delivery can be, adjustment by nurse or doctor only. All right, most can only be adjusted by the nurse. All right, this particular resolution clip can be adjusted by the doctor with a good rotation control. And you've got to know your jaws of your clip, whether there's the precision of opening and closing as well as tissue trauma. Size of the jaw as well as closure strength as well as some tactile feedback. Just like laparoscopic surgery, in endoscopic, you can actually feel the tactile feedback of the clip as you deploy it with experience. All right, I think I will run through this quickly fast for clip comparison. All right, but more importantly, I want to show you that there is difference in opening and closing length, strength, as well as size. And what I used earlier in some of the EMR were the largest one on the market, the 17mm 360 Ultra. All right. So I won't go through this too much, except for the fact that you've got to know your clips and how to deploy them. So here we have a large clip. I had a smaller clip deployed earlier on, but I couldn't go across the large defect on my right side of the screen. So this large, heavy Ultra clip managed to turn, twist, and at the same time I provided some suction, and I moved the whole defect forward, as you can see now. And in the next video, managed to put the whole clip across in the center. All right, thereby pulling the wound downwards for me to see the rest of the polypectomy. I apologize for the quality of the video here. All right. And enabling the first part of the clip to be done in this large defect, as you can tell. So now let's go to Emr Selection. I think you've got to review the CD if it's done by another endoscopist. Have them confidence whether you can do it the whole polyp or some piecemeal. All right, and counsel the patient for the medical risks as well as the fitness for the procedure, especially if they have cardiac risks or antiplatelets. I think the consent and risk of EMR is slightly different from just a routine colonoscopy. All right, because there's some increased risk of bleeding and bowel surgery. I normally give some intravenous antibiotics during the procedure, especially if they are large. And if they are elderly, I even admit them for overnight or even 2 nights for their recovery, because if they bleed, even though Singapore is a small country, sometimes the access to the doctor may not be fast enough for you to intervene. All right. Now, the equipment you need, I usually use carbon dioxide insufflation, endocarf, injection material, spot ink, all the materials that we've talked about. You need to be familiar in your team that does this endoscopic surgery. Now, ESD, I do less of. All right, I have done, but frankly speaking, a lot of the indications for ESD actually moves towards surgery. And then one of the knife equipments we use for ESD commonly is the duo knife. All right, Olympus has them as well. Very nice to use with the ceramic tip, but it is in untrained hands rather dangerous too, because it can go quite deep. And for ESD, it should be only SM1 and below. Once you reach SM2 or the depth of invasion, you should consider laparoscopic surgery. All right, so the indications are as such: large lesions, all right, especially with depressed tumors, all right, or repeat EMR patients with scarring. You might need to use the knife and do a submucosal dissection, all right, and of course, early cancer who refuse, or I guess decline surgery. I do offer most early cancer still a proper oncologic resection, but I think there will be those who decline it, especially for older patients. So my indications are such: large, not suitable for EMR, non-lifting, and perhaps early cancer who refuses surgery. Currently, I think ESD is still quite limited. I think with the robot that come in with 2 arms, I think ESD will be much easier to do. With the current tools that we have that's widely available, I think the suitability are quite low, and hence the learning curve will be quite challenging if you want to start your practice to ESD. I think one of the ESD things are best done for is actually a carcinoid, especially a rectal carcinoid. All right, this was a rectal carcinoid about 1.3 cm in size. So I went in and I thought, well, I can do a TAMIS, I can do a TEO, but we can do a ESD at the same time. So, and save the patient, OR time. So there we are on part of the ESD that you can see with the dual knife, all right, because it cuts very nicely. This is especially good for people who are starting out, because in especially the mid and low rectum, you feel safer when you're cutting deeper, all right, into the submucosal dissection. And there you have continued view, all right, as I use the dual knife to cut. And then here you have the almost complete ESD, all right, of this submucosal, of this carcinoid, rectal carcinoid. I got a bit tired after that, and then I just snapped the rest of it after this piece is taken out. Oh, I think I already mentioned that before, so that's what we did. A combination of all the techniques to do this rectal carcinoid. All right, so that's most of what I want to share for advanced endoscopy. I think this is Singapore. I hope you all can come and visit soon. All right, the suitability and safety of endoscopic mucosal resection needs to be assessed. Most of the time, you have got to know what are the endoscopic signs of massive submucosal invasion that were not candidates for endoscopic treatment. What's new? All right, in summary, I think endoscopic laparoscopic skills and the robotic platform are what all colorectal surgeons should be familiar with, so that we can utilize all of them in the current and future platforms of surgery for the patient. The use of AI to augment the scope and improve detection rate, as well as practicing your advanced endoscopy skills towards endoscopic surgery like EMR. I think all these are dedicated mindset for MIS that APELS advocates, all right? And think out of the box and have the skills to treat the patient in the best means possible with your MIS skills. For me, for large colon polyps, EMR is a workhorse of my excision. All right, you can lift it, you can do it. You can stage the EMR for safety. If a large polyp, 4 cm, 5 cm in size, you can do half at one go and do another half at another go, because sometimes prolonged sedation and insufflation has its risk for the patient. ESD, for me, I especially do it for large lateral spreading polyps, submucosal lesions, or for fibrotic tissues like redo EMR. And frankly speaking, for the surgeon, if you find that you can't use these other 2 techniques, let's just do laparoscopic surgery. Or if you have a colleague who can do laparoscopy while you do endoscopy, then you can present the polyp for yourself for easy snaring or easy EMR. I'd like to acknowledge the following. all right, APELS and Olympus, Boston, EastMed, Medtronics, Med Robotics, and my staff. All right, this is my staff on a good day in Singapore. All right, we're happy to see all of you, and thank you for your time.
Thank you, Dr. Jiunn. Thank you for that very up-to-date lecture with regards to lower GI endoscopy. We have in attendance a lot of colorectal surgeons also. And probably one of the questions that's running inside their head is, as a colorectal surgeon practicing in private, how do you divide your time between doing operation and doing your endoscopy list?
Okay, that's a very good question. Thanks, Ray. I think I find myself we in Singapore we have the fortunacy, just like in Hong Kong, that we start our surgical training with endoscopy. So it's very much a part of our practice. And I think if you correlate this with colorectal practice, we have the office procedures, what I call the hemorrhoidectomies, the fistulas, the simple fistulas and the fissures, and then you have your colorectal resection. So you treat it like that. You have an endoscopy, you know, you sort of, you enjoy the day with seeing some patients and doing endoscopy. It's just like a bread and butter, all right? And then you list your surgery. So I mean, that's how I do it. I don't have a formula, but I treat it as like a part of the day. So you treat it like your hemorrhoidectomy list. The colonoscopy list is like a hemorrhoid. But more importantly, in your question is that you need to have a list for especially the surgeons in training. There's no point doing an APELS course of endoscopy if you go back to your hospital and you do it only once in a while when you do in your own patients. You probably have to carve out a list with your hospital once you're accredited, to run a colonoscopy list every week. And I would say that the corollary to that question is that if you have a colonoscopy list every week of about 10 patients at least, you have a practice of what you do, and then you can then move on to more advanced endoscopy. I mean, for most of us, we have a colonoscopy list that's probably 10 patients a day or more. In the public, maybe even 20. In the private, probably about 5 to 10. We are already fairly busy. So I think that's something to have the numbers in our head to keep current.
Right. Thank you. So I think it's very important that you take it slowly, attend alternative learning experiences like this, an APELS workshop, then slowly build your practice and do your endoscopy, and then go into advanced techniques as you go along, especially those who are not into training anymore. So there are alternative pathways for training. I think that's very important. Also, I think you mentioned, of course, APELS espouses laparoendoscopic procedures, and you mentioned earlier the use of AI, machine learning. So this are already now, it's not a marriage, it's like an orgy of robotics and robotics, AI, and laparoendoscopic procedures. So it can be costly, but I think it can be costly in terms of practicing. But you were able to set it up in Singapore. Do you think cost will be a very big issue for us here? Or will the industry partner be amenable in helping us?
The most important thing, I mean, let's divide it to AI or robotics first. I think robotics is in endoscopy is still upcoming. I mean, I guess the research is mature, but it's not widespread. But you can see the use of it especially for endoscopic surgery. I mean, there are two arms in the scope you can do. I mean, the translation from laparoscopic to robotic endoscopy is almost, if you have it, you will use it. I mean, and you can translate easy. Now, the AI part, I guess, is very good for up and coming endoscopies to be using AI to check on their own polyp detection rate. I mean, I was started skeptical, saying that, wow, you just have a proctor, you can teach them how to see it, they should be able to see it. But frankly speaking, this AI is, I think, as a very valuable partner. You can turn it on or off at any time, and you can. The machine is just plugged into your Olympus or Fujinon scope. There's nothing else that you need to do. But yes, that machine costs a certain amount of money, and the partners, once they have it more widespread, the price would come down. But there's no extra cost of setting up a new endoscopy suite just to put that. You understand what I mean? You have an endoscopy suite, you just plug in. Yeah.
Right. Thank you for that information. Let me go to the Q&A box and the chat box. Can I read to you some questions? How do you label your specimen for pathologists? How do you set it up? Do you just place it inside a bottle with formalin, or you place it on top of a foam and then pin it down? Can you give us an idea how you set up your specimen for polypectomies?
You're talking about for EMRs? Okay.
Yes, EMR and ESDs. Of course, EMR might be a problem, but for ESD, probably.
I think, yeah, EMR may be a problem if you do it piecemeal, but I think the most important thing, maybe I'll answer the question the other way around, is that you've got to have a dedicated pathologist who's interested in looking at polyp and GI polyp specimens. If that would be the best first scenario, because if you've got a pathologist who do a lot of general pathology and they don't bother to see whether it's left or right side or where the injection marker or the ink mark specimen is, then you actually have a problem, because most of them will come back to say that there's something, or there's some high-grade dysplasia, but they can't see the margins, right? So that's the first. The second way to do it is that if you're certain this polyp is a mucosal lesion and you do it piecemeal, you're not afraid when some of the pieces come back as high-grade dysplasia focal in the center, because the pathologist can tell you it's high-grade dysplasia and not cancer. Otherwise, you'll be operating on a patient for nothing. The third, yes, if you've got an entire specimen, it's good to pin it on a foam board of any type you want. This is from any stationery then, but this is a routine you need to build into your scope center. And perhaps look at the specimen yourself, just like all of us who do surgery. Let's say you have an anterior resection, look at it, look at the completeness of the resection and mesorectal. You need to actually look at the specimen. If you need to pin it yourself, there's nothing wrong. Finish the endoscopy and go and pin it yourself and send it off. All right. Finally, if you don't have to pin it, sometimes I don't pin it because the whole polyp comes out as an entire very nice piece, and some of them are actually not too flat and comes out in piece. We can just send it in a formalin bottle. So I think there's a little bit of individualization of the specimens. Yep. But more importantly, is you got to look at the specimen yourself before you send it.
And I think it's very important that you have a very good pathologist on board, who has advanced training in GI polyp detection. Yeah.
Yes.
Okay. Can you comment on full thickness resection? I mean, as you said, the surgeon has a different perspective in terms of polyps and some lesions that are flat or laterally spreading. Comment on endoscopic full thickness resection. Since we are surgeons, you know, when we do our full thickness resection endoscopic, I mean, the surgeon can just close the perforation on the other side.
Yeah, I mean, I think within bounds of what I talked about earlier, we are talking up to submucosal dissection. When we are going to do full thickness, I think through the endoscopic means, I'm only happy to do full thickness when I'm in the rectum. In the colon, I find that if you've got to do a full thickness excision, means the indications is that you probably should do a laparoscopic colorectal surgery. Yeah.
Okay, you get it. All right. Yeah. There's another question here on the Q&A board. Well, I think it's a practice here in the country. Of course, as mentioned, the endoscopy suite is dominated by our physician friends, and sometimes when they do their ESD or EMRs, they do you do that? But of course, that has the risk of perforation for you is a double setup. But in practice, do you do double setup? I mean, if you have GI friends or GI is going to do the ESD or EMR, are you on standby to do the double setup?
Okay, Ray, just now, I think a part of 50% of your question was lost in transmission.
Okay.
But I can, I don't need you to repeat again, but my summary is that when you say double setup, which means you are on standby for the GI physician when he does the EMR.
Yes.
And when by this standby, meaning to say that if he encounters severe bleeding or perforation, you are there to help him immediately in the theater, or what? Sorry, I missed the first part of it.
Something like that. Something like that. That's the usual practice.
Sorry, I couldn't. I don't know whether Kadora or the rest who can hear it. I can't hear Ray, Dr. Ray at the moment.
The practice in the country is that there's a schedule, SD or EMR, then surgeon is standby.
Oh,
Is one of the practice, or probably among the panelists, is it common in your area? I mean, in Vietnam, in Taiwan.
I maybe I'll answer first, Ray, because I can hear you now. I think it's not common practice that we are on standby immediately. That means if you ask me whether when the gastro do a EMR, do they do it in the theater so that if there's anything we manage immediately? I think the answer is no. But we are on call to manage their challenges when it happens subsequently. So, for example, they do a EMR polyp, there's the bleeding, they will call us. I think this presents an opportunity for the surgeons to work with the gastroenterologist. I'm just talking about philosophically, and then whether you can do it, because we give them this support. You can discuss with the gastroenterologist to give the opposite support, meaning to say that you can then get them to be around while you're doing EMR, ESD, especially for the experts, so that it's sort of an exchange of roster at the same time, and you get your junior trainees who are interested in advanced laparoscopy to learn and work at the same time. I'm just talking about that practice. Yeah.
Thank you for that. There's still time for another question. There's a question in the Q&A. MRI versus endorectal ultrasound, which one do you use prior to doing ESD for a polyp? Or you just use plainly the classifications that you mentioned earlier in determining if you're going to do a endoscopic resection or just go for surgery?
In general, the good endoscopic view to get white light, narrowband imaging, or you can use a combination of chromoendoscopy, will be able to tell you the as well as the actual endoscopic palpation and lifting of the polyp. Will be able to tell you with more than 90% accuracy what is the classification and moving ahead. So I think I use that in the majority of cases. MRI and endorectal ultrasound are used for, I think, rectal lesions that have some doubt, I suppose, but not in the majority of my practice.
Thank you. So I think it's time for the next lecture.
Thank you very much. Thanks, Ray.
Thank you very much, Dr. Lai. For the third lecture, I'd like to call in Dr. Jiunn-Herng Lai. You missed also to introduce our next speaker.
Thank you, Dr. Sarmiento, and a pleasant morning to all our distinguished faculty and speakers, and to all the participants of this morning's session. Today, we are fortunate for having our guest speaker, who is well-renowned in the field of colorectal surgery in Taiwan and in the rest of Asia. He is presently the superintendent for the China Medical University Hospital at Hsinchu and an associate professor of surgery at the College of Medicine of China Medical University. He is a member of the board of directors for the Asia Endosurgery Task Force, the Asia Pacific Endo-Laparoscopic Surgeons, and the Endo-Laparoscopic Surgeons of Asia. He is also an international faculty for IRCAD Taiwan. Here in the Philippines, he is an honorary fellow of the Philippine Association for Laparoscopic and Endoscopic Surgeons and the Philippine Society for Colorectal Surgeons. Aside from having over 70 published literatures which have contributed to advancement of minimally invasive colorectal surgery, he is also member of the editorial board for the Asian Journal of Endoscopic Surgery, which is the official publication of ELSA. So to give his lecture on laparoscopic approach for left-sided tumors, the technical details and pitfalls, TME, LAR, and anastomosis, let us all welcome Professor William Chu-Liang Chen.
Can you hear me?
Yes, Professor, go ahead.
Okay. Well, thank you very much for your kind introduction. And I'm speaking on this topic on laparoscopic approach to the left-sided tumor. And I'm speaking in front of two experts, which is Michael and Leroy. They both are my mentor. Okay. Can you? So, well, I'm working in Hsinchu, a new hospital, as all my friend knows that for nearly 4 years now. And this is the hospital view. And today I'm going to talk a common practice of the left-sided tumor for colorectal for laparoscopic surgery. And for the past 114 years, I think open invasive surgery is replaced by minimally access surgery. And this is a pipeline, a line, that the history line showing how it works throughout the year. And I think for left-sided tumor, I think the most common tumor is the rectal cancer. And the principle of TME has well established by Professor Hill. And this is in 2005, I operated Professor Hill. And he also is the first person who videoed live transmitted his surgery using a camera here on the right corner, as you can see. And ever since then, we understand the embryology, the anatomy of the rectum, which that all of us are dissecting the embryonic plane here, and also, and we know the rectums. We know what's upper rectum, middle rectum, and lower rectum. And for the upper rectal cancer surgery, we know that we should do a tumor-specific or partial mesorectal excision. But for middle and lower rectal cancer, which is a tumor below the peritoneal reflex, we would like to perform a total mesorectal excision. And this is the principle that Bill have addressed to the world. And we also learned that the nerves are important. The nerves are important during the surgery, especially the sympathetic nerve, which control the urinary continence and also the ejaculation if you injure it. And also parasympathetic nerves should be preserved during the surgery. And this is, we know that during the surgery, we need to know where the nerves comes from, especially hypogastric nerve coming up from the top and down to the bottom. And also we know the fascias of the rectums, and especially the non-mediate and the Walder fascias. And we also learned that throughout the year, we also learned that we should examine our own specimen. So if the specimen is complete, nearly complete, or incomplete, we should state it. And this is the perfect example of this the specimen. And this is a specimen that I took it out last week on a TME case. But however, we know that if open surgery has more post-operative pain and longer recovery period, and physical disability is longer and more wound infection, incisional hernia, and also there are possible chances of bowel obstruction. Therefore, we're moving to minimally invasive surgery in the early 2000s. And why using laparoscopy, or we so-call it the minimally invasive surgery, is that we can see better with the high definition images, and we can train surgeons, not just one or two. We can train a lot through the video cameras, video through the now we so-called a webinar meeting, and we can also record our procedures. So when it's complication, we can really review it ourselves. And so there is a surgical care change during the past 20 years that I was involved with laparoscopy. When we first started, and the hospital does not believe in the laparoscopy, so I had to go to the market, to the supermarket, to the outlet to buy a TV that connected to the TV to our machine for the second TV. So it was different from now. Now everything is digitization and miniaturized. Even the scope is smaller and lighter, and the optic is much better. We have 3K, 3D, and 4K, and there are a lot of novel image techniques that's installed into our OR. So it's different from 20 some years ago when we first start our laparoscopic surgery. So throughout the years that we can see all the benefits that showing laparoscopic or hand-assisted lap versus open is better in terms of short-term outcomes, and also the complication rates are less when you perform a laparoscopic surgery as compared to conventional surgery, and the survival rate is higher, perhaps. And randomized trials for colon have also shown the same thing. And even on the Barcelona trial showing that it's better for stage 3 patients. Although the outcomes were not inferior, or were non-inferior of the open surgery, I think laparoscopy now is the golden standard of the surgery. So talking about laparoscopic TME, I think there's advantages and disadvantages. The advantage is better visualization in the narrow pelvics and better for training, because when we, in the old days, we have to stand in between leg for being a second assistant. You can't even see anything except retracting the abdomen, the low abdomen. And it's better for audition. So all the people who have all the surgeons who have a complication, you can review your own videos. And also difficulty is that it's technically demand surgery, and it's hard to assess the surgical margin, especially ultra low tumor, and ultra low cross stapling probably is something that we are worried about. Oops. So for sure that laparoscopic rectal cancer surgery or rectal surgery, it's hard. So it needs a 90 operation required to achieve the oncologic safety. And this was published by my good friend, Professor Chen. So that's why we need training. So in our practice, I'm going to go right into the way we do performing surgery and some of the pitfall and some of the tricks that we use during surgery. So for I usually perform this by myself or an assistant that's a nurse. So I always stand on the right side of the patient, and this is how I perform. I will perform a splint fixture mobilization first. So my procedure is coming from up to down, and then performing the rectal mobilization later. So I think it's important to choose the site of trocar. A lot of people try to save some trocar, but my point of view is that please add more trocars if you want it. So you don't have to. Do not concern about trocars that how many trocars that you use, but place on the right place is the most important. And I still follow the way Michael taught me how to insert a trocar. It just said for spleen flexure takedown, I would add another on the right upper quadrant. So I like to place my trocar in the wrong, like rounding it up. So when the tumor is right over here, I just wanted to surrounding the tumor so I can do my job. So during the surgery, you need to expose the rectum. So it's easy to just lift up, hinge up your uterus in some cases. I think in majority of the cases that you need to hinge the uterus. And for men with a thick peritoneal reflex here, you can stitch it up and hinge it like the way you hinge it up, the uterus. So exposure in this surgery is very important. And also, one of the important things that I did not mention is your cameraman. The cameraman is very important. To be successful, your cameraman needs to follow your hand, your working hand. It always put the working hand in the middle of the screen. And I guess this, I was taught by my colleague that they always put the working hand in the middle of the screen. And I follow this rule since the day I started to practice. So mobilization, you can do it medial to lateral, lateral to medial, and vessel ligation. And one of the important things is spleen flexure mobilization. I do it routinely, almost routinely, because of training my trainees. But in Asia, many of the patients, they have a very long sigmoid. Still, I still do a mobilization because for training purposes. So this is a lateral to medial. And recently, I found that it's really helpful for mobilizing my spleen flexure. So I frequently now doing the surgery from lateral to medial, especially doing a robotic surgery. I like to perform it to find the package first and then go medial to lateral. And of course, I'm also good in medial to lateral. I think surgeons should learn how to use how to perform surgery both ways, lateral to medial, medial to lateral. And I think it's beneficial for you when there's trouble on the side you were working, you can come in out from the other side. And what type of energy I use, I usually like to stick with my monopole scissors at 15 watt. And I use energy only to ligate the vessels. So are you gonna perform a high dissection or low dissection? Usually I perform a high ligation. I still believe that if you can clear everything at just around the aorta, it's better than doing a low ligation. If I'm doing a low ligation, I would like to do a high dissection of the lymph node around the aorta, like the Japanese does. And I like to separate S1 and S2 and left colic artery. So lots of systemic review are saying that whether you do a high ligation or low ligation, it does not matter. But the matter is tension. If you're ligating high ligation, you want to release more tension for the colon to bring it down to the pelvis. So, but actually you can do it both ways. So this is a part of your decision, which that I cannot alter it. So concerning of the spleen flexure takedown, spleen flexure is the complicated structure and easily associated with organ injuries such as spleen or a distal pancreas, and also margin artery. I'm going to leave this topic to the next speaker coming up, Alan Buenafe, he will specifically talk about spleen fracture takedown. So, but also I have to say it's involved with host fascia, gastrocolic ligament, pancreatical colic ligament, and spleen colic ligament, and also phrenic colic ligament. So I'm not going to go over it. So some tips on pelvic dissection. I think a good traction is important, and also sharp dissection, and also controlled bleeding is important. So as we learned from previously from Bill Hill, we know that here is this is the anatomy and the location of nerves and iliac arteries, which we have to stick with this principle while you're doing dissection. I think a good retraction is important. Once you have a good retraction, I used to use a cotton tape, but then when I have a lot of residents that's when they traction too hard and it might cut through. So now I use a wet gauze to tie it. So I think it's better to prevent the lesion to be tear. So while you do a dissection, you should be really careful of mobilizing it. Either you're doing a robotic surgery or you're doing a laparoscopic surgery, you're always following the plane. And I always tell my mentee about dissecting in between the parietal fascia and visual fascia. So this is how we dissect our mesorectum. So I frequently perform this surgery by myself. So my left hand is very important. I have to lift it up. Why by myself now? Because I came to a regional hospital, which it's a community hospital. I don't have a resident until this year, and because we just passed from the board of a surgery that we can train a few surgeons. So this year we will have a resident to come within us. Other than that, I always perform the surgery by myself. So I found that my left hand is important. As one of my tools is to practice on my left hand, doing a lot of traction for myself. So this is how we do surgery. And when to take the denal media fascia, like Bell Health say, dissect in front of the denal media fascia, in front of the seminal vesicle. It's when tumor located in the anterior. Then I would take it. If not, I'll just leave the denal media fascia behind. So if the tumor like this one is in the posterior, I'm not going to take it in front. I'm not going to stay in front of the denal media fascia. I'm going to stay in the posterior of the denal media fascia and behind it. So also the anterior section, what I'm talking is you have to have a very good 3D traction, like Gerald has said during his talk. This is a 3D. Once you have a good traction, and then you can create a very good. You can create a very good space. I mean, you can go into a good plane. So I like to perform this surgery meticulously, and I use only 15 watt, using 15 watt monopolar, either using a scissor or using the spoon like this, the dissector. So just follow the white line, so you can find it easily, dissect without any bleeding. So this is the anterior dissection. I think the posterior is easier. So I wanted to perform the posterior down as far as I can, as distal as I can. And then come into the lateral to open it up on one side. And then alternatively, you go right, left. And then you finish your dissection carefully. And about 30% of our cases undergo radiation. So doing surgery, you must be very careful on your dissection when patient with radiated pelvics, which is going to be more wet and it's more wet and also easily to bleed. And if we're not sure about the distal margin, we use a colonoscopy, which we have seen the light in the rectum. We use a colonoscopy to identify where the distal margin of tumor. So now after dissection, you remove the specimen. I think that one of the most important thing is the anastomosis. I think you have to assessing your surgical margin. And for ultra low cross clumping, I think 2 stapling is good enough and it's acceptable. If it's 3, I think you should do more dissection on your rectum. And good blood perfusion, which I currently use ICG to check all my anastomosis, and attention-free mobilization of the spleen flexure, and anastomosis reassurance using a colonoscopy. So I think current stapling causing an ischemic zone here, like because the staple can't go 90 degrees, so it's hard to do so. So this so actually you have to traction your rectum toward pull to the left side, so make it the angle better, and avoid more than 3 stapling. And this is how we do. And now for the rectum, I will use a cotton tape, and then I would like to track using the cotton tape as my steering wheel to traction the distal rectum, and then we will perform. We like to perform a better transection of the rectum. So for narrow pelvics, we usually use 2 stapling, and I use power stapling all the time, because for rectum, I think it's really difficult if you do not use power, just use the hand. It's hard to get an even distribution force. So attention-free anastomosis. A lot of people like us come to our insufficient bowel length. So insufficient bowel length, how do we, during the surgery, how do we solve this problem? Sometimes you accidentally injure your marginal artery, and what can you do? I think we can use a lot of spaces like retroileal, and also we can use the using the retroileal space to shorten the length of the bowel coming down, so we can do an anastomosis. What if we have 2 tumors like this? How? And we do extend left-sided resection. So I'm gonna show you a video of transecting the rectum, and then we know that we have also a distal, proximal descending colon tumor. So, and which means that I have to take a part of almost all the descending colon, and then do an anastomosis. So you can consider doing subtotal colectomy, but if the T colon is long enough, you can, which I perform is I try to go through a tunnel in the ileum, and this is something that either call over here. This is the ileocolic vessels here, and just go to the duodenal window to open it up. And then I can carefully bring the transverse colon down for anastomosis. This video was done by Isaac Shaw, Francis Shaw-Chun's son, doing his training with me 2 years ago. So this way you can solve the problem of not good enough length. So now we have a good length for anastomosis, and we do an anastomosis without performing any protected stoma. So another one is if you come to a short length for doing descending colon cancer, and this is too tight if you join the anastomosis. So what we do is we use the duodenal flexure. We do this created tunnel just from here, from the root of mesentery, and we have the colon come through this space. So we call this retrojejunal pull-through. Both of these two techniques were accepted, already published as in the literature. So now we have enough length for anastomosis. So we frequently, on the descending colon cancer, we perform an end-to-end stapling anastomosis intracorporeally. So this is for descending colon tumor. And for T-colon cancer, distal T, we can do it reversely. The same thing. We just pull up now we pull out the distal colon. We pull up the distal colon from this space again. So we just bring the descending colon up to make the anastomosis. So this there is because of using this, you can save a lot of our troubles. So again, we can join the bowel together using this technique. So also we can do this for if you doing a laparoscopic surgery for TME, and then you need to do a left side. I think we've done this stuff. So intraoperation scope is important. So we usually check our bowel doing the surgery. So we use a fluorescent scope to check our bowel doing the surgery. Okay. So anastomosis reassurance is next. We like to perform a reinforcement. Even on TME, we will suture our stapling down below. Suturing is good, but no evidence base. But it's good for junior surgeons to train their suture skill. And so frequently we will perform a suturing for every anastomosis that we make down below. So we have our trainee to practice on their suturing in a narrow space. So I make only 2-3 stitches, especially on the side, which I think it's release the tension of anastomosis after a good blood supply is preserved. So this is what we do. And then we check with colonoscopy. I think intraoperative colonoscopy, as mentioned by Michael for a long time. Michael even have taught us to use the colonoscopy doing to examine your anastomosis. So if you found out, like this case, we found out there's a bleeding here doing the surgery, after anastomosis, and then you can clip it, or you want to suture it from inside. So it's important. And also, like this case, we clip it with after doing a colonoscopy. So colonoscopy, doing our surgery, is very important and very important instrument, a weapon that you can use. So you can clip this lesion here. So I was on the top and Mina is in the bottom to clip the blood, the bleeder. So we can, so for this particular case, we can save post-operative complication. And also if there's a leak, and we can also just clip it right after surgery. And we use this to identify the tumor, a small tumor like this, so we can transect our distal margin. So at the end, I would like to address a little bit, spend a little bit of time talk about the robotic surgery, which I've been doing a lot since last October. I think we are exceeding our 70 cases, reaching our 70 cases since October, and the entire hospital is reaching nearly 100 cases for using robotic surgery. I think robot, especially at the time, I was really against it. I even make jokes about robot, but now with the XI, and I even asked opinion for Michael. Michael say if you have one, and then you have to do it. So it's more expensive sitting the robot on the side of the wall. So I tried it, and for Da Vinci XI, I think it's really good. So now we perform about 3 to 4 robots per week in my department, the Department of Colorectal Surgery. And I think it's easier than before, and you can do a very good rectal dissection. For this case, this is a very advanced tumor after radiation, and it's easy. Although the robot is saying that it's no benefit as compared to laparoscopy, but the clinical outcome, amazingly, it's less pain, even though there's no evidence-based. And I think people would like to argue, especially my good friend, Loha might argue that if you can perform good in laparoscopy, why are you doing a robotic surgery? But I think robot cannot compare with laparoscopy because both are minimally invasive. But robot, I think laparoscopic surgery may be as a Ferrari, but robotic surgery, maybe it's better than Ferrari, I believe. A robot is, although it's not as smart, but right now, currently, I believe it's an expensive laparoscopy with good camera vision and good ergonomic. So there's no proven benefit, but increased costs, longer operating time. We all know this, but it's investigating. But I think if you have one, try to don't be skeptical about it. Try it. And Joel say if you have $2 million, buy a surgeon, not a robot. But now if you have $20 million, buy a robot and many surgeons. I think this is my point of view from robot. At the end, I would like to say that understanding of anatomy, plain surgery, vascular control is important. Energy, especially you can use bipolar energy and ultrasonic energy. The best energy in combined probably is the one from the old brand, the Vanderbeat, and good traction doing surgery is important in sharp action and tension osmosis. And remember to keep to buy a colonoscopy, which is not very expensive, and put it in the OR. So a general surgeon or colorectal it's mandatory for you to learn how to use colonoscopy and use fluorescent image if it's available, and protect your anastomosis. Don't be afraid to create a protected ileostomy or T-colostomy. And I thank you very much for your attention. Thank you. I can't hear you.
Professor Chen?
Yeah, now I can hear
It's
you.
clear. Thank you for that lecture. It's thank you for your very vast experience in the left side colon lesions. Can you hold on for a while until we are done with the right side? We'll ask Dr. Joel Leroy. Did I pronounce it right, Professor Leroy? We'll introduce you properly. We'll ask Dr. Gretel Puson, one of our MIS surgeons, to introduce you properly before you deliver your your lecture. Gretel?
Thank you.
Thank you, Dr. Sarmiento. Good morning. It is my honor to introduce the next speaker. He is the founder and chair of the Hanoi High-Tech and Digestive Center in St. Paul General Hospital, as well as a professor honoris causa, Hanoi Medical University in Vietnam. He is a world-renowned surgical expert, innovator, and researcher. He is the leading pioneer in the field of advanced laparoscopic colorectal surgery, having trained thousands of surgeons around the world. To talk about the laparoscopic approach to right-sided lesions, ladies and gentlemen, Professor Joel Leroy.
Thank you. Thank you for this kind presentation. I'm sorry, I'm sharing. Do you hear me?
Professor.
Yes, I have a voice speaking. Oh, okay. Do you see my lectures now?
Yes, we can see your slides now.
Okay, thank you. So I have to speak.
Yes, can you present the slides, Professor? I think it's the.
It is a slide.
No, you're not showing the slides. It's side by side with the screen of the Zoom app.
Sorry, no, I don't see. I will share. Have you this?
Where?
You have it now?
Yes.
Sorry, it's an error. I don't know why. You have my slides now?
Yes, sir. We have your slides now.
Okay, thank you. So many thanks for this invitation to participate with a lot of friends, world expert from Asia. And thank you too to the team of Philippines, a fabulous country I've visited a long time ago, and particularly to my friend Buenafe and his colleague Sarmiento. I have to give some information concerning the laparoscopic approach of right side lesion, and to, as just did William Chen, to speak of details and pitfall concerning the particularity of right colectomy, where we were speaking of CME and CMV and CVL in comparison with rectal resection. Concerning oncologic surgical colonic resection for cancer, it is important to have a good standardization, to have the best results in oncology. And it is particularly described in the literatures, not only for open, but also for laparoscopy. And it is more recently, in beginning in 2014, that Hohenberger, German surgeon, introduced CME with CVL. But I will say that all the colorectal surgeons were doing this type of procedure, but they don't know they were doing, or they were doing D3 lymphadenectomy and with colonic resection. There is a consensus concerning oncologic resection. We have to do adequate lymphadenectomy. That means minimum 12 nodes, depending of the segment of bowel, where is the tumor. And adequate bowel resection with a distal margin of the tumor more than 5 centimeters, with a cylindrical division of the bowel and meso. A proximal margin with a minimum of 10 centimeters and lateral margin of minimum 5 millimeters. I'm thinking tumor in contact with other organ as a small bowel or with abdominal wall. You have to resect more than the bowel. The number of nodes removed is important, particularly in stage 2 and 3 of colonic cancer. These results support consideration of the number of lymph nodes that evaluate that it is a good measure of the quality of colonic cancer resection. But this is not evidence-based for this. It is a weak evidence-based. What kind of lymphadenectomies we can do in colonic cancer? It is important to have in the mind the lymphatic nodes map, Japanese classification. When we watch these drawings of the colon and rectum, we are interested by the colon, we can see that there is epicolic nodes that are the most proximal lymph nodes to the bowel wall. We have paracolic nodes that are located along the marginal vessels. We have intermediate nodes that are found along the named vessels of the segment of bowel and drain to the principal nodes that are at the origin of the SME for the right colon and or IME for the left colon and rectum. When we do a D1 lymphadenectomy in right colectomy, we will remove the right colon and the epicolic and paracolic nodes. This is the first type of lymphadenectomy. When we do a D2 lymphadenectomy in right colectomy, we will remove the same as D1 and the intermediate nodes along the main vessels. And when we do a D3 lymphadenectomy, we will remove the D2 and the central apical nodes that are the principal lymph nodes group accompanying the vessels of the colon. CME, described by Hohenberger in 2009, is a technique with three essential components that are, first, the central vascular ligation to completely remove all the lymph nodes in the central vertical direction. This is D3 removal of lymphadenectomy. With a resection of an adequate length of bowel to remove involved pericolic lymph nodes in the longitudinal direction. So this is the length necessary with a distal margin minimum 5 centimeters, proximal margin 10 centimeters. And the dissection between the mesenteric plane and the parietal fascia, removing the mesentery within a complete envelope of mesenteric fascia and visceral peritoneum that contains all lymph nodes draining the tumor. This is in comparison with TME for a Bill Hill for the rectum. For that, we have to know the anatomy of the meso and fascia. We see for the right colon that and the left colon too, ascending and descending colon, they are fixed posteriorly to the posterior wall, and the bowels organ are attached to the posterior wall, and they are said to be retroperitoneal organs secondarily. When concerning the other segment of the colon, we can see that the sigmoid mesocolon is fixed posteriorly, the mesentery and the small bowel are fixed posteriorly, and the transverse mesocolon too, but they are not stuck on the back of the posterior wall of the abdominal cavity. What is an adequate lymphadenectomy in colonic cancer? Doing a CME with CVL or a D3 lymphadenectomy, and what is the difference? The CME and CVL is a Western concept described by Hohenberger. The D3 lymphadenectomy, it's an Eastern concept, but for me, they are similar. Technical details and pitfall in laparoscopic right colectomy for cancer, I do. First, we do a perfect installation of the patient that will be on the operating table, the left arm along the body, right arm also eventually, or perpendicular to the operating table. We use anti-Tredellenburg position, and the legs are retracted. I'm staying between the leg of the patient because there is different possibility for the surgeon staying on the left side of the patient in mirror than for left colectomy, or between the legs. Since the beginning of this surgery, I'm staying between the leg of the patient after I have tried to begin on the left side. I know that majority of surgeons are doing this surgical procedure staying on the left side. But more and more, and I know that William Chen is changing too, but also robotic surgeons are putting the robot between the leg. And for example, for single port procedure by Giovanni Dapri is staying between the leg with a suprapubic incision. Number of trocar, you can do with 1 trocar to 5 trocar. 5 trocar is good when you begin. We can reduce progressively the number and the size of the trocar, but as you will see, if you do completely inside the abdominal cavity, the anastomosis, you will have to use trocar to introduce stapler. And the first step, as said William, it is exposure. It is the exposure I use with one assistant of the left side of the patient to maintain the transverse mesocolon retracted cephalad. My surgical strategy consists to separate the right colon from the left colon. And for that, I will go from down to up, dividing vessels, transverse mesocolon, transverse colon, and omentum, and divide the ileum, distal ileum, at around 10 centimeters of the ileocecal junction, and to free the attachment, posterior attachment of the colon. For that, I will use, as you see, this position, staying between the leg of the patient to have ergonomic position. And the first step is the exposure using anti-trader and bow position and left lateral tilt. I will push cephalad, the omentum above the transverse colon, and with the trocar in the left hypochondrium, I will grasp the transverse mesocolon to maintain the transverse colon cephalad and to expose the root of the mesentery, mesocolon, and transverse mesocolon. So exposure is the first step. When we have exposed, it's time to do the vascular approach, central vascular approach. For that, we will dissect anterior to the superior mesenteric vein. As you see, exposure will not change during all the procedure. And my first step of surgical strategy is to divide all the vessels, divide at the origin of the vessels, removing the nodes around. This is a central vascular ligation, and to remove the node around those vessels. As you see, we find the ileocholic vein, the ileocholic artery, crossing anteriorly, in this case, the superior mesenteric vein. Sometimes this artery it's crossing posteriorly, and we will divide between clip, removing the nodes around. So we do elective division of the vessels and between clip, and we continue the dissection going more medially. In this case, we will have accessory right colic artery crossing the SMV, and we will divide it, and we go more medially to find the middle colic artery coming from the superior mesenteric artery, and we will have a division in a right branch and left branch, and we will remove the nodes and keeping the left colic branch and the trunk of the middle colic artery. In this case, we will divide the right branch. So finally, we will have divide all the vessels coming from the superior mesenteric vessels going to the right colon. This is another node we remove, and we will divide the meso and the right branch. When we have finished to divide this branch, we have to complete the vascular division, coming back to the gastrocolic trunk of Henle. You see this trunk with different branches, right colic vein, gastro-omental vein, and behind or above the artery, and the pancreatic distal vein. We separate, we can keep the trunk dividing only right colic vein, gastro-omental vein, and keeping the vascularization of the pancreas. So this pancreatic vein, we don't divide the gastrocolic trunk of Henle. As you will see, we can seal the vein, or we can clip with adapted clip to be sure that we will not have postoperative bleeding. So this is the standard, only to explain that I'm dissecting the vessels, I'm separating the right mesocolon from the mesentery and from the transverse mesocolon without mobilization of the colon. This is advantage. This is not time consuming, because when we mobilize the colon rapidly, we have to expose more, we have to do more manipulation, and it is longer time. So we are separating the gastro-omental vein, and as you see, I do all by posterior medial from down to up dissection. It's not doing by lateral approach. So we have done this. When we have finished, we have to do, I suppose it was, yes, it is finished. So we will have to do anastomosis when we will have removed the colon. And for that, we will do side-to-side isoperistaltic anastomosis, fixing the ileum to the transverse colon with 2 stitches and using a stapler. This is anastomose in, and we will do that, as you see, using a linear stapler, 60 millimeter long. Usually it's a blue cartridge, and we complete by a closure of the orifice we have introduced, the stapler. This is done with a perfect colonic preparation, even if the majority of people are saying it's not necessary in the right colon to do a bowel preparation. Personally, I prefer to have a washout and a good bowel preparation for a lot of reasons. If we have to do perioperative colonoscopy, it will be easier and better and less risk of contamination. We can do also, after exteriorization, the anastomosis outside, but we prepare the anastomosis, fixing the stitches inside the abdominal cavity to avoid a twist and problem of torsion doing the anastomosis outside. We can do the anastomosis cheaper with by manual sutures or with a stapler, as we have seen inside. Concerning the specimen removal, we can remove the specimen just in front the transverse colon, around the umbilicus, in suprapubic. It is what people love to do because reducing the risk of incisional hernia. And also we have the possibility, it was described, to do a removal through the vagina in female patients. When we remove, as you see, we have to put bowel parietal protection with plastic wound protector, and this is what we do routinely. To see the extension of the difficulty we have sometimes to extend the right colectomy, this is in case of transverse tumor of the right transverse or mid transverse, and we have to do extend right colectomy on left transverse colon. And this is what we will see with the removal of the nodes, D3 or CME with CVL. This is what we will see. But only to remember, when it is a transverse tumor, we have to dissect and to remove the omental vessels where we have nodes inside. And if we wish to do perfect lymphadenectomy, we have to remove this kind of vessels. Sorry, we cannot. We do same position for the patient and exposure. This is a T4 mid transverse tumor, and we have, as you see, the nodes just in the meso. And we do right transverse colectomy with right colectomy with mid and mid transverse colectomy. So we do same vascular dissection as you have seen before, with right colic vessels divided. We will divide the mid-colic vessels in this case, and we will do a division at the origin of the mid-colic vessels, and we will remove all the nodes, as you will see soon. This is the right omental artery, just above the right omental vein. We have to do, as you just saw for right colectomy, this is similar, but we will complete medial and lateral left, doing a division of the attachment of the omentum to the duodenum, using a posterior medial approach. This avoids to manipulate too much the colon, transverse colon and the omentum, and we complete the division of the attachment to the stomach, attachment of the omentum. And this is done by down to up and by posterior approach. And as you see, when we do the division of the attachment anterior to the pancreas, we have seen the tumor falling. We will complete the dissection going more laterally on left. And this is what we are doing, arriving on left. And we will arrive at the level of the back of the splenic flexure. We divide the ileum to complete the division of the ileum at 10 centimeters of the ileocecal junction. We do the freeing of the posterior attachment of the cecum, and we complete the division of the posterior attachment. This is CME we are doing, staying anterior to the parietal fascia. We do the distal division. In this case, we do on the descending colon to have easier anastomosis later. We have kept the left colic artery. We divide the left omental vessels now. This is the tail of the pancreas. We do the division, removing the node and to complete with sealing the attachment to the stomach. And this is the hand of the resection. It's time now to do the anastomosis between the ileum. This is a side-to-side isoperistaltic anastomosis between the ileum and the descending colon, removing the, after removing completely the colon. I have to do that. Question, is CME and CVL or D3 lymphadenectomy always necessary? In early cancer, particularly T1, T2, located at distance from the principal artery, the incidence of central metastatic nodes is insignificant. This is a Japanese society of publication that conclude that in early cancer, perhaps it's not really necessary to do so large resection. But despite this, some authors propose to do always a CME and CVL approach for all stages of colon cancer, and CME with CVL or D3 lymphadenectomy in early constitute a good treatment, even if it is an over-treatment. But we have to imagine some tumor located, for example, in the cecum, ascending colon or right flexure, and the transverse. And we see that the vascularization, we can have a good easy oncologic resection in early tumor for this type of localization. And this is what we can do, for example, in early case, doing a cecal resection. And this is what you will see. In this case, we can do ileocolic resection, removing the nodes. I'm speaking of early tumor. We will say, for example, T1 SM2 polyp resected, and we wish to have analysis of the segment of bowel and of the nodes. We can propose this type of resection. This is ileocolic resection, and this is segmental resection, oncologic enough for cecal tumor. And we will do ileocolic anastomosis at the end. This is a CME. We are staying anterior to the Gerota fascia and posterior to the third fascia. We do the division of the ascending colon, and we will do the ileocolic anastomosis as we have seen before. Other case, and this is to have a discussion with our friend Professor Lai. This is a polyp of the cecum, and you see if we do ESD, EMR for this localization, there is a risk of perforation, and we can have a hybrid surgical procedure using endoscopic and laparoscopic, so it's endolap cecal procedure, and perhaps a safety technique is to control by endoluminal endoscopy and doing a wedge resection to remove this segment and to be sure that there is no perforation. What are the recommendations? For the Japanese Society of Colorectal Cancer, the treatment recommended is a D3 lymph node dissection for T3 and T4 or N+ disease, and D2 lymph nodes can be proposed for T1 and 0 disease. But we know N0 after. D3 lymph node dissection is basically recommended for stage 2 or 3 colon cancer in a tertiary surgical center. Even if D2 lymph node dissection can be performed for T2 and 0 disease, we recommend doing D3 or CME with CVL right colectomy. In conclusion, radical oncologic approach in colonic cancer is optimal with CME with CVL or D3 lymphadenectomy. These may not be necessarily applied in early stage of the tumor, but with a good diagnosis in a trained team. Respecting a good standardization, you will have good oncologic results using laparoscopy, and this seems similar than to have a large surgical procedure by open. Thank you for your attention.
How I do it portion of the workshop, we have two excellent surgeons, colorectal surgeons, ready to answer your questions. May we open the Q&A box and see if we have questions for the two professors? All right, let me start the ball rolling. Maybe we can entertain one or two questions. Professor Chen, William? Yes. With your ICG during your ICG, doing your left-sided resection and then doing your ICG, what's the timing and dose of ICG for when you want to check your anastomosis or the vascular supply of your left?
Well, yeah, I understand. If I perform an ICG, I perform before transection of the rectum and colon. After mobilize all the mesorectum, and then I'll check with ICG. And I don't do it for lymph node because I think it's not evidence yet. But for ICG, we also measuring the time that exists. So within we're doing a study now, and David is doing a study now, seeing what's the time, the best time to for it to show out on the screen. So we perform it almost routinely for the patient before transection of the bowel.
Thank you. Professor Leroy,
Yeah.
you mentioned earlier that for lesions in the right side of the colon, you espouse a CME or a D3 dissection for right-sided lesions. Would you espouse a critical view of, to standardize the steps, would you espouse a certain critical view of safeties in close quotation for right colon resection? I mean, there are certain steps or guides to standardize the procedure. Would you agree that everybody follow that, or it should be a free-flowing way to do surgery, like go from medial, and then if you can't, see the landmarks, you go from lateral to medial. It depends on the situation or the intraoperative findings.
I think for right colectomy, worldwide, there is not a complete consensus concerning the approach, because I know a lot of surgeons coming, it's less and less, coming from open, and they love to do first mobilization of the colon. And it's not my choice. I will say similar than left colectomy. I have seen that William said he can do first a mobilization of the laterally of the colon, but I think it is mainly to have the possibility to have a good traction on the rectum. So he's mobilizing in case of lateral fixation, and to have the possibility to expose better his rectum and to do a good traction on the rectum. It's why he's mobilizing probably first. But personally, I always use medial or medial posterior, even for the transverse colon, as you have seen. And on left too, I'm doing medial posterior approach. And why? Because I think it is due to my position for working. I'm between the leg, and if I don't do like this, I will have the colon falling always in the field I'm dissecting, and I have to do more exposure or more trocar to have necessity to expose and more manipulation. And as you know, manipulating colon with tumor is a danger, and particularly in case of big tumor. And my choice is, as I have explained, first medial, medial posterior, and at the end mobilization.
Thank you, sir.
I don't know, but I think William now is doing also like this, if I remember, because his colleague Chen presented his the experience of his department, and they were doing like this between the leg too now. Is it right?
Yes, yeah, we do it. We perform many operations between the legs. It's called the French position. So I like it standing
for
in between
cholecystectomy. It's for
the legs. Yeah, so we like it standing in between. See, either you work in on the right side or left. Okay, even if you look at work on a splenic flexure cancer, if you stay in between legs, I think it's a good position. And for right colectomy, I want to add some of my experiences. The original CME, you need to do the cockpit maneuver, and you have to remove a lot of the bowel. And this is something that I would like to ask Joel about your opinion. I tend to follow more of a Japanese way of doing it, which is 10-10 rule, which is 10 centimeter away from the tumor and 10 for both sides, and also the following the dissection of the artery, D3 dissection, we just clear the main artery lymph nodes, so you can remove less bowel, you can preserve more bowel, and I think it's less complication if you do a lot of not less complication. At least you don't need to, for a cecal cancer, you don't need to sacrifice as much length of colon. So, and for T1 tumor, I will perform a D3 dissection because I think there's some main node involved. So I would like to ask your opinion on that, since you always say that T1, T2, you don't need to do a D3, and T3 or above, you perform a CME. So I just wanted to know if the length of bowel that matters to you.
Honestly, it was cut regularly when we were speaking. I don't know if it is the same with me, but you ask, what is your exact question?
It's, do you perform exactly the way that was illustrated for CME, or you have modified the CME?
No, I don't know. You see, CME is three components. You have vascular approach, you have length of resection. This is for the lateral nodes close to the tumor. And I don't remember. And the complete lymphadenectomy. This is a standardization of procedures. So when we do the vascular approach, finally, if we do a complete vascular approach, we will remove completely the colon. So the length resected, as you said, I suppose, because I have not well listened your comment, is it 5 centimeters necessary, or we can do more? With the colon, we can do more because we have no limitation. It is not the distal rectum with 1 centimeter, 2 centimeter, or perhaps very distal rectum, 5 millimeter distal margin. It is not similar. With the colon, we have no limitation normally. And we have only to do resection, keeping the vascularization. This is a problem of vascularization, and we will be oncology. And it's not only the bowel, it is the meso. We have to do a resection, removing the nodes. The second component of the CME, that is lateral diffusion on the nodes. Central, it's for the proximal nodes, and central node, and the lateral dissection is for the length of resection. For T1, if we are sure it is a T1, and normally I do that, cecal resection, if a polyp is removed and they said it's a T1 SM2, for example. I wish to have analysis of the nodes. I will do segmental resection of the bowel, cecum, and the nodes depending of the cecum.
Thank you for those.
Normally, cancer will be right colectomy, removing the nodes with central vascular ligation.
Thank you for those clarifications, Professor Leroy. So I think the point here is to get as much nodes as you can, and lateral margins be adequate. Okay, we now move on to the third part of the morning session, the tips and tricks. I'd like to call in Dr. Rafael Resection to introduce our next speaker, who will talk about splenic flexure takedown tips and tricks. Dr. Resection. Thank you, Professor Leroy. Thank you, Professor William Chen.
Thanks.
Sorry, sir. Good morning, everyone. For our next speaker, he is the Executive Director of the Philippine Center for Advanced Surgery at Cardinal Santos Medical Center, a board member of the Asia Pacific Endo Surgery Group, the President of the Philippine Hernia Society, the Board Director of the Philippine Association of the Laparoscopic and Endoscopic Surgeons, Joint Secretary General of the Asia Pacific Hernia Surgery, an honorary fellow of the Japan Society for Endoscopic Surgery, also a past president of ELSA, and our program director for the Unified Minimally Invasive Surgery Training here in the Philippines. To talk to us about splenic flexure takedown, our very own Dr. Alfred Allen Buenafe.
Thank you, Alex. Hi, Joel. Good morning. I miss all the group. we should be seeing each other face to face again. Hi, William. First of all, I would like to thank William, Joel,
Hi, Alan.
Craig, Jiunn-Herng Lai, and of course, Michael Lee for this opportunity to be able to hold APELS again in the Philippines. Can I start sharing? Okay, my lecture will be about splenic flexure mobilization. Welcome to the third part of today's series for lecture series for colorectal surgery. Anyway, my lecture will be about splenic flexure mobilization. It's one of the tips that we can actually give when we're doing our laparoscopic colon surgeries. One of the most difficult part in your left hemicolectomy would be to take down that splenic flexure. And I think it's one of the steps that we need to clear out for the participants, especially for the participants for the hands-on. I don't have any disclosures. We all know that your splenic flexure mobilization has been one of the challenging parts in doing your left hemicolectomies. For sigmoidectomy, there's no problem because you have quite a long sigmoid colon, especially for Asians. We've seen a lot of Asians with a redundant sigmoid. So doing a resection and anastomosis is not difficult, but doing a formal left hemicolectomy, you'll end up with a little bit of tension and you need to do a splenic flexure mobilization. More often than not, if you do that, you'll end up either crossing to another boundary or having some difficulties in taking it down because of all the 5 attachments that have been explained by Professor William Chen earlier. So in this presentation, I'll be doing your the inframesocolic, the supremesocolic, and the lateral to medial approaches when we do our splenic flexure mobilization. So there's a lot of procedures and a lot of ways on how to take down that splenic flexure mobilization. So we all know that at least 40%, about 2/3 of the left-sided malignancies are at the left side. And more often than not, for a formal left hemicolectomy, you need a splenic flexure mobilization. It's done for your both the benign or the malignant disease, elongation of the remaining colon after resecting the descending colon. I think the most important part in doing a splenic flexure mobilization is to secure your anastomosis without any tension. We all know that a leak rate would increase if you have tension. It's technically challenging and a quite high learning curve. And hopefully, after this session, you'll have an easier time in bringing down that splenic flexure. Although that the mobilization of the splenic flexure is not always necessary, it's sometimes mandated for a tension-free anastomosis. It's a very complex procedure or maneuver because of the close proximity of your left of the splenic flexure to your pancreatico, to your stomach, to your spleen at the left side, upper left side, and can potentially devascularize the large intestine to be used for your anastomosis. There's a lot of things that you would want to take note of. That splenic flexure mobilization entails careful division of your ligaments, ligamentous attachments, like your pancreatico-colic ligament, your splenocolic ligament, the gastrocolic ligaments, and the phrenico-colic ligament. So all of these things, these 4 ligaments would comprise all attachments, and you need to take it down to be able to have a good splenic flexure mobilization. And also you need to have a complete mobilization of that line of Tolt or that ligament of Tolt at the lateral side. So these are the things that you would want to look into. For me, the way I look at it, all procedures would be easy if you have a good grasp of your anatomy and a good understanding of where that ligaments and that spaces would lie. Even for the left hemicolectomies or right hemicolectomies, it's all about anatomy. So if you look on the studies, this is a very old study at the start of the colorectal era, or the start of the laparoscopic era for colorectal surgeries. They've stated that there are 5 issues that are quite funny to take note of. Is the right colectomies at the early start of laparoscopy was considered to be the easy procedure. But right now, because of CME, CVL, and all the things that, especially the D3 dissection, I think right colectomy would be at the one of the most difficult procedures to do in your colorectal surgery. Anyway, in this study of Jamali, he said that the sigmoid colectomy, the left hemicolectomy, low anterior resections, and the splenic flexure mobilization would be at the one of the difficult parts to do. So splenic flexure resection and transverse colectomy are rated as one of the most difficult parts, scoring at least 4% to 4 and 4.1% respectively. So let's start with the anatomy, understanding that anatomical variations in this area. So it's important to understand that the location of your splenic flexure is in relation to the different organs at the fascial layers of the fascial planes. The root of your transverse colon, mesocolon, is on the caudal side, caudal edge of your pancreatic body. Your pancreas is here, and the tail of your pancreas. And the mesocolon spreads out from there in the characteristic fan shape. So you have to understand that the body of your pancreas going up would be your pancreatico-colic ligament. So if you're going down from the inferomedial going up, the first ligament that you'll be transecting would be the spleen, the pancreatico-colic ligament, and you need to open it. And you don't want any injury to your pancreatic side. The dorsal mesentery consists now of your sheets, originally and then becoming 4 sheets, forming your omentum between the stomach, the transverse colon, and the third sheet of your dorsal mesentery. That becomes the dorsal wall of the omental bursa. While the 4th sheet of the dorsal mesentery and the ventral leaf of the transverse colon are usually fused. Medyo nakakalito, no? Sometimes quite confusing, but suffice to say, when you lift your transverse colon, you have that bursa from your omentum. Diba? You have your omentum that connects to your transverse colon going down. So you need to open up to be able to identify that space in between the bursa. Then from the bursa, another space that connects it to your stomach. So these are the things that you'd want to to be able to identify, especially from that bursa, the omental bursa, going down to your pancreatic area. So these are the things that you want to understand and try to prevent injury, especially at the mesentery side of your transverse colon. So you don't want to devascularize that the area of that transverse colon. It's relevant also to note that the procedural aspect of your splenic flexion mobilization should consist of the splenocolic ligament, phrenicocholic, the gastrocolic, and your pancreatico-mesocolic ligaments. So you can follow me, right? So these are the ligaments that you'd want to identify. Then, of course, the left mesocolon forms the left fascia of your third fascia in diffusion of your peritoneum at the left side, at the dorsal abdominal wall. The only anatomical landmark for dissection between the fusion lines of this fascia and the deep subperitoneal fascia are the spermatic vessels and the ureter. So dissecting it laterally, if you're starting it from the lateral side, you want to identify your spermatic vessel first, and then your ureter at the almost at the midline. So these are the things that you want to check. So your left spermatic vessels and then your left ureter. So we have three approaches for your splenic flexure mobilization. You have your anterior approach, the one that we open up that omental bursa, trying to identify it, going laterally, and then going to your TOTS fascia at the lateral side, going up. So we call it the anterior approach. The lateral approach, you start off with your TOTS fascia on the lateral side. If you're starting off with your surgery after dissection of and identification of inferior mesenteric artery, you go lateral and go up, and then identify that splenic flexure. So that's the lateral approach. The inferior medial approach is quite more technically challenging, but I think it's anatomically better because you identify all the layers. It's between your transverse colon and the pancreas, but identifying that pancreatic area going up is a little bit difficult. So let me show you some videos on how we do it. So lateral approach, this is the splenic flexure. So you divide the lateral peritoneal attachment. This one is after dissecting and identifying that inferior mesenteric at that area. So going down, having been identified that medial approach, so this is now your colon, this is your transverse colon. Then taking down the phrenicocholic ligament, and your splenocolic ligament. So anong ligament? This is your omentum and your colon, di ba? The ligament that connects the omentum and the colon. So this is how we do our lateral approach. So you start off at the lateral side, then going up. So at the top would be your omentum and your colic attachments is taken down. Then laterally, you take down the splenocolic ligament and be able to identify everything. That's now your stomach. Identifying now the gastrocolic ligament and taking it down. So once you approach it and you have taken down that gastrocolic ligament, you'll be able to identify the pancreatico-colic ligament. So opening up. So once you've opened this, you'll be able to identify the pancreas, right? The body of your pancreas going to the tail. Now you'll be dividing the pancreatico-colic ligament. Then going lateral, you'll be able to take down your splenic flexure effectively. So you'll have a very loose splenic flexure now. If you do this one, you'll be able to bring down actually the transverse colon down to your pelvic areas. It's quite easy to do. So taking down all the attachments is now easier. So the next one would be your superior approach. The superior approach is you need to divide the omental attachments to your transverse colon. So you start off taking down that omentum that's attached to your transverse colon. So you try to identify which part of your transverse colon that you would want to bring down. You can actually bring down the whole transverse colon if you want. So a mixture either of an advanced bipolar device or a monopolar device, I would usually make use of a hook, our endoscopic shears, or a bipolar device. This one is a ligature. You can also use your thunderbit. Taking it down, taking all the superior attachments, and releasing that splenic flexure. So mobilization is done again, taking all the ligaments down. Then your proximal gastrocolic ligament. After doing it, that's the start. That's the only time that we start doing our medial dissection, our medial to lateral dissection. So identifying now our inferior mesenteric artery. This is our IMA, identifying it to be able to take hold of it. And then this is the midocolic artery, just to be able to bring down everything. I think this is a splenic flexure tumor. That's why we took down everything and bring down that transverse colon downwards. So this is our superior approach on how we do it. Anastomosis is done intracorporeally. And of course, our inferomedial approach. The inferomedial approach, so after ligating your inferior mesenteric vein, identifying it, I do it the way William Chen had taught me on how to do it. So you identify your inferior mesenteric vein, you ligate it. So once you've ligated your inferior mesenteric vein at the root, that is the space that you would want to do your dissection going up and try to identify your pancreas. Going up, going from medial to lateral, the first thing that you would want to identify is your ureter. You would want to save that ureter. So from that inferior mesenteric vein going up, you would want to identify now the line of fault. Dissecting it, going lateral and medial and going superiorly, you will encounter now the edge of your pancreas, the body of your pancreas. So you'd want to identify it, then go up superiorly at the pancreatic area. So this is now your pancreas. You go up and identify that space. You have to take note of the anatomical variations in this one, especially if you go more inferior, you'll end up doing your dissection at the inferior area of that pancreas. So if you do your dissection here, it will be at the posterior part of the pancreas. Going up, you'll be able to take control of the pancreatico-colic ligament. So if you can take note of this one, this is now your body of your pancreas. Then your stomach. Okay, so this is your pancreatical colic ligament. And you just carry it out going to the lateral side, your pancreatic, your splenic flexure area. After identifying it, you go superiorly and take down the omental attachments at your colic area near the splenic flexure. Actually, it's a variation and a mixture of procedures. So you just mix and match the anterior approach, lateral approach, and then ferromedial approach for your splenic flexure mobilization. The most important part here, I think, is a good understanding, a good grasp of your anatomy. Once you've identified it, it's easier actually. It's very easy to do. So you've done your dissection at the medial side. After doing that, you start now doing your lateral dissection. I'm sure you've seen a lot of left lateral dissections coming from your, when you're doing your LARs. So you start off from your medial to lateral, and then from the lateral side, you go your dissection and then identify it. With this one, we've done all our mobilization of the splenic flexure prior to the dissection of the lateral. So if you notice, once you start your lateral dissection, it's just a matter of connecting the dots from the lateral side to the medial. So nakabukas na lahat, no? It's all already open. Once you've done this, it's elementary. It's very easy now to do. So we love, if you noticed, all the speakers, we love to use our monopolar shears doing our dissection, primarily because of it's faster and you'll end up with a cleaner dissection. So again, following your line of thought. So this is now your, this is now the line of thought going up, identifying. So this is your Gerota's fascia. So try to identify, because we've already dissected inferomedial, so it's just a matter of opening up and lining up everything. And the last attachments at the lateral side are taken down. So now you have a very free left splenic flexure, and you'll be able to take down that splenic flexure area freely downwards. Then you'll have a very nice anastomosis without any tension. You can do this in 30 minutes time, actually the splenic flexure dissection. I think it's just a matter of, you know, slowly taking it down. So you have a good area of splenic flexure, transverse colon going down. So you have now a full splenic mobilization. So you can do your long dissection, as has been stated earlier. It's not the length of the bowel that's more important. It's actually the length of your mesentery at the specimen side. So you would want to get as much as lymph nodes for your specimen. So as a conclusion, the goals for your splenic flexure mobilization, you have to have a good length of colon for a tension-free anastomosis, a splenic release for distal transverse and proximal colon tumors, and you have to take note of the anatomical variations in this area. Nice thing about anatomical variations for your splenic flexure attachments, it's all the same. Although the additions would be different, but the variations are almost the same and almost identical to each one. So you just have to identify the layers of the bursa from the bursa and then going down to your spaces. So there's no gold standard approach on how to approach your splenic flexure mobilization. I think it's more of understanding how you would want to approach that splenic flexure and having a good grasp of all patients' characteristics. You have a short stature patient, I would start off with a superior approach. If you have a fat patient with plenty of omental and mesenteric fat, I would approach that patient with an inferomedial, because I don't need to identify with the top to bottom, kasi it's a sea of fat when you go inside. So rather than suffering identifying all the layers, I'll go start from the inferomedial, going to the pancreatic area. It's easier and the fat are less, it's easier actually to identify the structures and the spaces rather than taking care of all the sea of fat. So these are the things and the variations that you want to get into if you would really want to go into more advanced colorectal surgeries. So a good technique is very important than a assertive approach when deciding whether the splenic flexure needs to be mobilized or not in surgery. In most experienced surgeons, they will know that the tumor location, if you need a splenic flexure. But mostly for Asian patients, you can do away with a splenic flexure, but there are subsets of patients that you need to do. So I would want to end my lecture today. If you have any questions, I'll be more than happy to answer it. Thank you very much.
Thank you again, Dr. Buenafe. Another excellent lecture from one of our experts. I think we're still on time or on point, but I think your lecture is intimately related to the lecture of Professor Chen. So if Professor Chen can stay a lot longer, we'll ask questions later on after the lecture of our friend from Australia. We have Dr. Kevin APELS to introduce him properly. Kevin?
Okay, good afternoon again, everyone. Professor Lee, Dr. Buenafe, and Dr. Sarmiento. Our last guest expert lecturer for today is Professor Lynch from Australia. He is a colorectal and robotic surgeon in Australian Robotic Colorectal Surgery and in Sydney Adventist Hospital in Sydney, Australia. He's a clinical associate professor at the Australian National University. He is also an associate professor of surgery in Columbia University in New York and an associate attending surgeon in a New York Presbyterian Hospital, Columbia University. He is also a board member of APELS. Let us all welcome Professor Craig Lynch for his lecture on troubleshooting in laparoscopic colon surgery. Good afternoon, sir.
Thanks very much. Nice to see you all. I think Kadora is going to play my video for us. So today I'm going to be talking about troubleshooting when we're doing laparoscopic colon surgery and talk through some of the strategies that hopefully might be able to get us out of trouble. So when we're operating, all sorts of things can happen, and the aim is really to have some degree of preparedness for that. That involves analysing the problem, and to get a patient to a good outcome, there's a lot of things that can interact to cause trouble. There's a bunch of human factors. There's also team factors such as communication and interaction between people in theatre and other people in theatre competent to do the appropriate tasks. There's patient-specific factors, and there's also factors that relate to the surgeon, such as their competence, training and experience. So there's about a dozen things that can really be seen to have a negative influence on how any task, and surgery is one of those, where in terms of it can impact on performance. We can be distracted, other stresses can interact, we can be tired, pressure of the job or other things can cause poor outcomes. Also things like complacency from the surgeon themselves or other staff, and just people assuming that the norms of what normally happens are occurring. We can see lack of teamwork, lack of awareness, lack of assertiveness from all staff, lack of knowledge, lack of communication, and then lack of resources that are available. All these things can interact on an outcome, and it's important that us as surgeons are aware of them and then try and do something about reducing them. So let's get back to surgery. When we're operating, sometimes bad things can happen, and then sometimes things can compound. So here we've got a bleeding vessel and we've lost vision. So what do? Immediately people will start shouting, playing with monitors, trying to swap your laparoscopic camera over, fiddling with the light cord. Then the consultant comes back in and sees that there's no image, but you know, that's okay because he doesn't know something's bleeding. And then the scrub nurse hands you a scalpel and just wants you to open. What do? Well, all these things can interact at once, and what happens is you get an issue where you need to have a plan. If you've got a plan, you can work through things and actually get a solution. Part of the key is it's all about task saturation. A lot of things can happen at once, and this increases the chance of human error. So checklists where you have a plan and you work through things in an organized fashion are a good way to get better results. So pilots are the usual people we think about who use checklists, especially when handling emergencies. A checklist is really a sequence of actions, and it's got a predefined order that's in order of importance. It includes all those factors that you might overlook in a stressful situation. So if something bad happens to a pilot, first up, remain calm, keep flying the plane. Don't crash, don't forget about the weather, make sure you've got enough fuel, communicate, review what's happening, and then manage the immediate threat. So that's what pilots do all the time, and it's useful when we're thinking about things that can go wrong in surgery to do the same sort of things. So find out all you can about a problem, estimate and assess what's happening and consider possible solutions, choose a safe, practical solution, work out what you need to do that solution, and then do it. Reassess it and revise the plan if necessary. Now, don't wait for a problem to happen. This really starts right back before we've started operating. When we walk into a laparoscopic theatre, we've got to make sure things are set up to reduce the chance for a problem before we even start. Have we got the monitors in a good place so the entire operating room team can see them? Things like CO2, do you know if it's going to be a plumbed supply or are you relying on gas bottles? And if so, have you got an adequate supply for a long operation? What sort of operating table have you got? If you decide to break an operating table in the middle of the theatre to get some flexion on the patient's abdomen, have you got the patient positioned appropriately to do that? Have you got stirrups and are they the right ones? Have you got an advanced energy that you're going to need? Is it available? And have you got the disposables that you're going to need? Do you think you might need a colonoscope? If you don't have one at the start, how long is it going to be before you get one? Is it a 20-minute wait while one's sterilized, or is one readily available? And all the consumables that you might need, like staplers and extra ports. And then other things like, do you need to record it? And if you do want to record it, does everyone know how to turn it off and on? So checklists have come in a number of things we already do in theatre, and the WHO have shown that a timeout at the start of an operation does reduce complications in all manner of ways, from wrong site surgery to using antibiotics. But as they've said, implementing a checklist is a complex socio-technical endeavour. As providers, we've got to change our approach to a task, and we've got to be able to engage in cultural changes that make sure it works. So as surgeons, we've got to lead the way and embrace checklists. And we know that if we do, things like antibiotics are given appropriately at the appropriate time and reduce wound infections, and teamwork is potentiated, and there's less chance of having a communication error. So often with timeouts, it's a good chance to really sit there and think about what's going to happen with the operation. Not only are we going through the checklist, but you can actually use that time to work out what's going on around you and communicate with the team, with the anaesthetists, work out if there's an experienced anaesthetist or an anaesthetic registrar there, and what other staff you have available and who's engaged with the process. It's a good time also to think about patient positioning. We don't want trouble with patient positioning. We often place patients in steep Trendelenburg. That does bad things to their airway pressures, give them upper airway edema. And if they're not firmly fixed to the table, they can get a brachial plexus injury. Lithotomy position's got its own set of problems like perineal nerve injuries, and it's also a good chance to check to see if you've got DVT prophylaxis and inflatable leggings on. Important to think about before you have a problem. No point trying to fix it later. Also, when you're thinking about patient positioning, you can make a laparoscopic operation really difficult by not setting it up correctly in terms of ports, table positioning, surgeon and assistant positioning, and even where you've got the monitors. Think about it before you start. You don't want to make a problem for yourself that you have to fix later on. So you can get underway, you know where things are, you're communicating with your operative team, and you can get on and start your operation. So if you want a case to run smoothly, you need to communicate. Everyone in the theatre needs to know what's happening and what's going to happen. The staff that they need to know their jobs, they need to be coordinated and flexible. People need to be familiar with the equipment. That's going to shorten the operating time, but also reduce the chance of having problems if you're trying to sort out an issue. So something like laparoscopy, and especially robotics, make sure your assistants know how to use the equipment. That might mean actually having a dry lab session where you discuss these things and run through them so everyone is up to speed with what's happening. So that means when you have a problem, you might be able to then deal with it without too much trouble. Now, something like loss of vision, there are checklists that have been generated so you can start off before a case and check your laparoscopic equipment, and then during a case work out what's happening. Now, this checklist is only useful if you know about it and have read it before you start a case. And it's worthwhile thinking about something like this and running through in your own mind what you're going to use if there's a problem in your operating theatre. It's too late to go and find out when something happens. And this is simple things like understanding that light cables do wear out, and you've got to make sure you know you can identify a bad light cable and know when to fix it. And the advice is fix it before you start, not during a case. So does it work? Well, yes, it does. Surgeons will get half as many errors with their laparoscopic gear if they use a structured checklist. So you can reduce issues with positioning, connections and equipment, and incidents that happen during surgery if you start off with a recognized checklist that you have run through. So think in your own mind, maybe look one up and then use it before you start. If you finally manage to get underway, there's a few things that happen at the start of an operation that can make it go easy. Is the tumor marked, and do you know where it is? It's very hard to take out the right bit of bowel if you don't know where a cancer is. So maybe there's a tattoo that's been placed and it's easy to find. If you can't find a tattoo, what do? Maybe you've looked preoperatively at the endoscopic pictures that were taken by your gastroenterologist, and you've worked out where the tattoo is in relation to the tumor. And here you can see there's a tumor, there's a tattoo, and you can see the ileocecal valve in the distance. Maybe if a tumor is not tattooed, you might want to do an endoscopy beforehand and actually tattoo it then before the patient comes to theatre, so you know how to plan the surgery. And if it's surgery, you can't find the tumor, maybe you've got to think about using that colonoscope you've got available so you can get someone to place the colonoscope, find the tumor, and then you can identify it laparoscopically as well. Much better than trying to resect a bit of bowel where there's no tumor and leaving a cancer behind. So when we're starting, especially with things like anterior section, you've got to know where structures are. And one of the key things we really do like to know about is a ureter, and having a plan about finding a ureter, if it's not easy to find, is really important. Sometimes it's pretty straightforward. It's sitting there in the right place, behind the right plane, and you can see it and continue with the operation. That might not always be the case. So what are you going to do? You can do simple things like back off and then think about where it might be up on the pelvic brim. You can put a stent in that's either lit, or you can use ICG with it, which is really useful if it's difficult to find. And you've got to have an awareness either on the right or the left side of the pelvis where that ureter is going to be. Sometimes with ICG, it's really useful because in difficult cases or diverticular disease, it might be a little bit out of place. And then using something like ICG can really mean you can find it and avoid having to dissect it right out and risk damaging it. Now, the anastomosis is one thing which tends to happen right at the end of the case. All the people in theatre have switched off and want to go home because it's been a long day, but it's got to go really well. And often this is where people get a bit distracted, and if you're not getting it right, problems can occur. You don't want to have a twist in your anastomosis. You've got to make sure that you're thinking about it and you've got the bowel appropriately placed. And that's a matter of checking before you fire it. Now, air leak tests are one of those things where everyone does it, but often people don't think about what they're seeing. You've really got to do it well, get the bowel blocked off, underwater, and really look for bubbles, because you've got to do it well to make sure you're seeing what you want to see, i.e. is there a leak that you can fix? And again, colonoscopes are great to have in theatre because you can visualize your anastomosis. It's a great way of insufflating the bowel, and then you can deal with problems that occur. If you've got bleeding, or if you've got a small hole, sometimes a resolution clip placed with a colonoscope will fix it very easily, and then you can just get on and finish the case. The other thing I'll say about anastomoses is often if there's a longer rectal stump, it can be very hard to get the gun to the top of it. Don't push and force it because you can damage that proximal part of the rectum, which may mean you get a suboptimal anastomosis. Think about what you're going to do before you try and force the gun up there. Often a really safe way is to do the anastomosis in the anterior wall of the rectum. Of course, if you're going to do that, think about where structures like the vagina might be so you don't damage those. But sometimes this is an easier, safer option than having to shorten down a strictured up proximal rectum. Now, if you get a tough case, it all comes down to planning, I think. You can troubleshoot as you're going with cases that are tough, but it makes a lot more sense to have a plan before you go in. So this was a case with a great big carcinoid node sitting on the aorta. We had a good plan, we got it all mobilized, and it went very straightforwardly, but having a plan before we started certainly helped. If you've got a tough case coming up, get a roadmap. Correct anything you can correct that's going to make it easier. If you're going to be dealing with ureters or it's stuck on a kidney somewhere with a bit of colon, make sure you're comfortable with the renal function on the other side. It's not good to have to sacrifice a kidney if you don't know that the other one works. Don't overbook yourself. If you've got a tough case, put it early in the day and don't overload the afternoon. Make it so you've got time to deal with problems that might occur. And then plan ahead, think about what you might need, things like stents and urologists, other stuff like that. Make sure they're available before you start. Now, blood's an interesting one because blood and blood products vary in their availability between hospitals. Work out what you're going to need before you start and plan ahead. Maybe talk to hematology. And then think about extra help that might be needed along the way. Think about who the theatre team is beforehand. Maybe discuss the case with them. That's always a good idea. Talk to anesthetics. Talk to your urology colleagues or vascular colleagues if you think you might need them beforehand so they can plan to be available, if not actually there in theatre. It's a good day if you've got a tough case to make sure you've got a competent assistant, and sometimes even ask a second surgeon to be involved or at least available. Colleagues are always really happy to help if things are tough, but we're even happier to help if we know about things beforehand and we can prepare to make ourselves available if there's an issue. And one thing we always want to talk about is bleeding. Sometimes, no matter what happens, bad bleeding occurs and it can make life pretty tough. What should we do? Well, the first thing is anticipate if you're going to get in trouble with bleeding. plan and then have a backup plan for what might happen if you really do get in trouble with bleeding. And that means planning good central access before you start. And again, knowing the blood product status for the patient and availability within the hospital. If it takes 3 hours to cross-match blood, then waiting till you've got a big bleeding vessel is not the time to find that out. And again, communicate. If you've got a big bleeder, most hospitals will have their massive transfusion protocol. Activate it early. Pressure, communication, and waiting before things are set up, before you have a go at fixing a decent bleeding vessel, is always going to be a better outcome than trying. If things are really bleeding, you have a short window before you get in trouble with blood volume and then coagulation status. The more blood you lose and the more resuscitation you need, you get in that lethal triad of hypothermia, acidosis, lack of coagulation, more bleeding, and you've still got a vessel to fix if it's a really bad bleeder. So stop, get everything in place, and then act. The anaesthetist will thank you for waiting till they're ready to go. And as things are going, make sure you give the anaesthetist a good running account of what's actually happening. They need to keep on top of things to keep the patient well, and that gives you an opportunity then to fix the problem. It's always good to have a friendly hematologist who can help out with coagulation when you're in trouble. It's not just a matter of giving platelets, there's other things they can do. They can do TEGs and other rapid assessments of coagulation as bleeding's happening, and then they can control the blood products that they're giving to you, which can help really optimize what's up. Because if you get in trouble with coagulation, you may end up just having to pack and go to intensive care and come back later when the patient's resuscitated. Active management by someone who's interested in what's happening to the patient and their coagulation in real time is really useful. And sometimes bleeding can end up with big losses, and so you've got to be on top of that. For colorectal, the one thing that often will get people in trouble is the presacral fascia, and you can get massive venous bleeds from this area, and even laparoscopically that can be audible. Be aware that's going to get you in trouble, and you need to treat it seriously from the outset, and don't try to fix it, because you'll end up in trouble with a high volume loss and still have something you have to fix. Pressure, prepare everyone, pack the pelvis, and then with all hands on deck and as much help as you can get around you, try and repair the damage. Sometimes that's often it's open and thumbtacking down the sacrum, the presacral fascia back to the sacrum. Sometimes it's even a matter of packing the patient and sending them off to think about using radiology to see if they can block the vessels off. But be careful, it can be very difficult in a situation. Once you're in, you've got to manage aggressively. Something else I thought I'd talk about in terms of troubleshooting is self-assessment and looking at your operative videos and going over them and really thinking about what you're doing and how you can do things better. We know, like, if you have an operation like a lap chole, we can assess that for quality of the procedure, and there are things that we can look for, like lack of progress during a dissection, damage to the gallbladder, damage to the liver, wrong dissection planes or non-target tissue burns, tearing, instruments moving in and out of view, and maybe a supervising surgeon has to take over the operation from a trainee. So we can use all these to assess performance, and it's really useful to do that yourself and think about things quite objectively in your own operating techniques. Did I have appropriate traction when I was dissecting that? Have I got the ports in the right place? Am I doing things in a way which makes it look clumsy, and can I improve that? Am I using an energy device correctly? And even decision making in terms of risky choices, like trying to do things rapidly and prioritizing speed over carefulness. All these things can lead to poor outcomes with surgery, and more trouble than we really need to be in. So objective viewing of your own videos and self-reflection of how you're doing an operation can improve your performance, and that improves your performance next time, which may reduce the chance of problems in the future. There's a lot of things we can look at that can change the way we do an operation. So self-assessment and review are very useful things to do. That's about all I want to say. There's a couple of quotes I want to leave you with. Now, this is a Latin quote: "Sweeter after difficulties. A success always feels better if it's been a tough road to get there." And this is not the way we should be thinking about surgery. Really, if you want a quote that fits to how we should be doing surgery, think about this one: ready for anything. Planning means we can do things safer and better. And that means less stress, less complications, and at the end of the day, a better outcome for our patients. Thanks very much.
We're now open for questions. I think we still have on board most of the APELS member or APEL board members to answer questions. Can we check on the Q&A board? I think we missed out a question earlier, but the question was with regards to bowel prep for left-sided and right-sided lesions. What kind of bowel prep do you use? Professor sorry, that's for Professor William Chen. And for I'll post some questions for Professor Lynch later. Okay, maybe we can go back to that question. Dr. William is not online, so we'll post questions for Dr. Buenafe and Professor Lynch.
I can do the answer for William.
Hello?
Because
Hello? Hello?
Hello.
Yes, Professor Leroy.
No, because William did the answer, that is performing anterograde bowel preparation.
Naririnig niya ako? Claro?
I have a voice.
Konti
There's
pa
a
sa-
voice. There's an. Okay, can we? All right. Okay, some technical difficulties. Professor Lynch, some preparation. Troubleshooting for that.
Ma'am, okay ba?
Yeah, so in terms of prep, I always prep my lefts and don't prep my rights.
Right. Okay.
And I usually do an intracorporeal anastomosis, and I don't worry if I haven't prepped them.
Okay.
So I repeat, William wrote, because there was a question concerning bowel preparation, and he did the answer. He performed anterograde bowel preparation, and if there is a partial obstruction, he is doing only retrograde bowel preparation for left. As I said in my lecture concerning right, personally, I love to do bowel preparation, to have a clean bowel, because we do the anastomosis inside the abdominal cavity, and we can have more contamination than with the left colon. And I do also oral bowel preparation on the left side. And with my friend, we demonstrate that it is the only prospective randomized study published in the literature concerning the left colon, I will say sigmoid and rectum. There is a real benefit doing a bowel preparation.
All right. Thank you, Professor Leroy. Professor Lynch, With regards to your robotic surgeries, do you think how many cases would you say, or what's the level wherein a surgeon is ready to go into robotic colon surgery? I mean, a lap surgeon or a colorectal surgeon doing laparoscopic colon resections. When do you think that the learning curve for colon surgeries or laparoscopic colon surgeries is overcome, and then you're able to shift to the robotic platform?
I think an experienced laparoscopic colon surgeon finds it a lot easier doing robotics. And normally you're very comfortable by about sort of 30 cases, like you feel very confident. The interesting thing is the more robotics you do, the more you tend to like it, and you tend to drift that way rather than do laparoscopic surgery. So, but certainly once you're experienced laparoscopically, it's pretty easy to change over.
Right. With regards to some preparations also, do you do the French position or the open leg position also when you position yourself?
Robotically.
Okay. Okay.
So interestingly, robotically for my rights, I do use like a French position approach with the ports sort of very low and transverse.
Okay.
Yeah.
And then the rest, you can do it from the side of the patient.
Correct.
William Chen mentioned earlier that on left-sided lesions, when you want some tension-free anastomosis, you can go through the transileal route to be able to bring down that transverse colon into the rectum. And do you often do this, or do you think adequate splenic mobilization is enough to bring that colon down into the pelvis?
It's pretty rare that I do that, but certainly possible. And so you've got the option, you can either go through the ileum, or you can mobilize the colon completely and flip it.
Yeah, flip it, yes.
And it depends on the quality of the bowel you've got and how it's going to work. But sometimes if you get into that point, you can do that, and it will give you extra length.
Okay.
I mean, you know, working in Australia, virtually all the time we have to take down the splenic flexure because we have quite a short sigmoid, and it's usually poor quality with lots of diverticular disease. So we're always mobilizing the flexure.
Right. And so do you do appendectomies? I mean, do you do the appendectomy also when you try to flip the colon?
Oh, not usually.
Not usually.
Invariably, appendicitis is diagnosed on CT. So people tend to know where it is.
Okay. All right. All right. Maybe last question before we go for lunch, and then later on 2 p.m. we will go for the video presentation of our fellows. For your anastomosis, when you do your anastomosis, do you prefer going through the staple line, or just go for a fresh or a virgin part of the colon and then you do your staple anastomosis?
For an anterior, I would tend to go just in front of the staple line. That would be the perfect spot. Yeah.
Okay. How about you, Professor Leroy? Do you go through the staple line or go for a virgin part of the colon?
If the spike is going through, yes, but what it is more important for me, it's to avoid two ears. It's to do to introduce more in a corner, and usually it is the right side for colorectal. The one I'm seeing very well. So I have a long ears on the left side, and because you have a difference of size for the circular stapler on the rectum and the colon, usually, even if you have side-to-hand anastomosis.
All right. Dr. Buenafe?
Why? Because you will have a risk of ischemia if you have too small ears.
From too small ears. So you try to avoid that. Okay. Dr. Benepe, same. Okay. Professor Lynch, do you use ICG?
Yes, if I've got it available, I will. Yep, absolutely.
And I mean, in Australia, do you do your on-table colonoscopy to check for anastomotic lines on the left side?
Yeah, I try and have a scope available in theatre. Yeah.
How about in Vietnam, Professor Leroy?
I would say I don't know Vietnam only, but Vietnam in Asia, not Australia, not I don't know Australia, but it seems it is similar than West countries concerning patients. And we have very slim patient. We see very well the vascularization. We have good analysis of the quality of the vascularization. And I don't use ICG for the diagnosis. And fistula in ischemia are very, very rare.
Thank you. Dr. Benefe, any comment?
I want to say same concerning the tension-free anastomosis using transmesenteric or other tricks for doing tension-free colorectal anastomosis after extensive resection. I have used during the last 3 decades only 3 times. So this is, as said Greg, very rare to use these tricks, but it is important to know.
Maybe for diverticular disease, when you have, hostile colon, maybe that would be very, very useful. So I think, Dr. Benefe, no more comments. I think same sentiments with the other members of APELS. I think it's time to go for a break, and we'll see you later at 2 p.m. Thank you very much, Professor Lynch, Professor Leroy. Thank you very much. Dr. Benefe, thank you very much. So let's go for a break and then come back at 1400 hours.